Okay, so we go to this session. The session is on the work package 2. Is the work package, and I'm introducing myself. My name is Marina Davoli. I'm an epidemiologist, and I'm based in Rome at the Department of Epidemiology. And I'm coordinating the work package 2 together with colleagues from different institutions in Italy, which have the common characteristics of all belonging to the Alessandro Liberati Association Italian Cochrane network. We originally coordinated this project, this work package. And this work package has to do with using this site for coverage decisions. For the policymakers and managers and their support staff with responsibility for making coverage decisions, which we intend as decisions by third-party payers, public or private, health insurance, about whether and how much to pay for drugs, tests, devices, or services, and under what conditions. To put this in a context, we refer to this report of the Organization for Economical Cooperation and Development, which makes quite clear that the health system and the coverage decisions that come from these systems are responsible for just one part of health, and much is behind that, is between education, occupation, and other social promotional activities. But the thing is that we want to know that what we spend for the health services has a value in terms of health. And we know that most patients assume or would like to think that doctors and other healthcare providers are giving them care of the highest quality possible using the latest knowledge and most efficient technology. Also, the healthcare funders would like to think they are getting the best possible value for their money. Unfortunately, we know that both groups are often wrong. And what is this report advocating for is that we find explicit structures or processes to help payers, purchasers, make informed decisions on coverage of pharmaceuticals, costly new technologies, but also other types of services are needed, because if we pay for something, we don't pay for other things. And this is the context where the framework from going from evidence to coverage decision is in. And of course, there are the main job in these years, together with the other work packages, and particularly the work package 5, coordinated by Andy Oxman and his team, that has to do with health system decision, we came up with these domains that we think we need evidence on to inform coverage decision. So we need evidence on how serious is the problem to become a priority for a coverage decision, how much is the certainty around values, and how much is the uncertainty, and how much about the relationship between the balance between benefits and harms, and how much we know about the resource required for an intervention to be covered, and what is the cost effectiveness behind it. And what's the impact on equity, and is it applicable, and is it feasible? So I think these are the domains that we need to find evidence on to inform a coverage decision. I think we are quite well in providing evidence on this, on the balance between benefits and harms, and we still have to work better to find a way of identifying the evidence for the other domains that are very important to inform the decision. All these domains do contribute with different weights according to the different decision to a coverage decision that is not a dichotomous decision as we could think. We can have an easy answer if we think on the basis of all these domains that will not cover the intervention we want to cover, but also we could come to the conclusion that we want to cover it, but only within evidence development. So we don't have enough evidence to cover it straight away for all the population, but we want it within a specific study to evaluate it. And or we want to negotiate the price according to the knowledge that we have gained, or we want to restrict the coverage to a certain subgroup of population. For example, we are all talking about the use of new anticoagulants. For example, we want to decide that we will cover it only for a group of people that are not compliant to warfarin and are not able to check their coagulability state, or other examples. And eventually, we decide for coverage. So this is the spectrum of the decision that we can take. It's not an easy task. What we are going to do further is you will see the framework within the workshops that during these days, and we want to use these frameworks in real life. You can see some poster presentations. We think that these frameworks have been contacted by people of the HTA organizations in Netherlands or also in South America, and could be useful as a tool for implementation to be as an addendum to HTA reports. We hope to have a link with the European network of the HTA organization. Go on user testing this, because probably this is one of the most, it's a very challenging area to put all these decision, to try to inform the difficult and the puzzling decision-making process. So to user test this framework in real-life situation. And we still have a question on how to evaluate whether it works or not. It was clearly pointed out in these days. We need to know whether this is going to make a change or not, and what kind of change. Can we design multi-site trials? And I welcome, and all the group welcome people who like to be involved in all these different phases that we are going to develop further. A colleague of mine sent me this picture. She had the chance to visit the Scottish National Gallery that thinks worthwhile seeing it. So it's very challenging, and we are not thinking of doing miracles. I think the best thing we can do here is make this decision-making process as transparent as possible in the criteria that have guided the decisions. And so I like to invite the first speaker to talk, and his name is Carlos Aito. Carlos Aito is a physician, and he is now Director General of a health district in Rome, which looks after the health of half a million people. He was involved with the DECIDE project since the start with Alessandro himself. And what we asked him is to tell us whether the DECIDE tool might be is useful for a policymaker to take a decision. What should we do? What should we do next? So, Carlo, please.
Hello. Good morning to everybody. Thanks to Marina and to the organizers who asked me to speak today. As Marina told, I used to be a clinician for about 20 years, but now I am a health administrator. So my perspective is, well, I wouldn't say changed, but it's changing, I may be daily. And in this respect, I feel a little bit, like a fish out of the pond here, because, I think I'm the first decision maker to talk in this Congress. So I'm a little, I hope I will that's something useful and debatable. So, instead of starting from the tool we have and how it is up to now, I thought it was more useful to start with some opening questions, which means what do we need from a decision tool as decision makers, and then what do we get from the decide tool as it is now, what do we still lack, and more, how do we know whether the decide process is working, and finally, where should we go next? I think these are maybe the most relevant problems we have. The first is to pose relevant coverage questions. And second, to formulate the question in answerable terms. Then to get an effectiveness-based answer, to get a timely, context-wise answer, to assess the quality of the decision, and to assess the impact of the decision. From a decision maker point of view, I think these are maybe not the only ones, but some very relevant questions, some very relevant themes. And I will try to tell you what I think these areas really mean. To pose relevant coverage questions. This is really pain in the neck. You know, we are submerged by the most extravagant requests by a lot of people, mainly clinicians. And it's really difficult to try to find out which are the relevant coverage questions. I think because we confront different meaning of the term relevance. We have somehow an intrinsic relevance of the problem. So we are confronting a problem and we can investigate the relevance of the problem, I would say, within the problem. How large is the population involved? Which is the difference of the new device or the new procedures with respect to the existing ones, and so on. But then there is a comparative relevance, which means, is this my priority in terms of relevance or not? And how can I decide? Just first to come, first to serve, or there is something more I should have to navigate the relevance? And beside these, there is an additional problem that most of our requests come from clinicians, and most of our requests come from clinicians who are very interested in new technologies, new techniques, not only technologies. And they asked to implement these new technologies. And this is a clinician-driven, but also, I would say, a market-driven relevance. Because new technology is more likely to be proposed than, for instance, an organizational change. And I would say, together with these, the importance of a public health-driven agenda. Who's the agenda we are trying to carry on? And how the relevance of the issue of the coverage we are trying to assess can be read within this framework: intrinsic versus comparative, clinician-driven versus public health-driven. The second point is, how can a question be put in answerable terms? This is a problem we had when we started trying to apply DECIDE, because we tried to pose a question and then we said, well, but this question actually posed different questions, and maybe it applies differently to different population, so we have to continuously trying to reformulate to have a question which could be answered in specific terms. In this picture, everything is easily resolved. We have on one side all of life's answered questions, and on the other side of life's questions answered. I wouldn't say that we should only pose questions for which we already have answers, but definitely we should pose questions that can be, really and effectively answered. The same problem, I think, is what we have with research or clinician decisions. With the PICO framework, which was, shortly presented and illustrated yesterday, I think we still lack a PICO solution for health policy question. I think we should invest in drawing something similar to PICO, but related to public health decision and coverage decision. This is what I think we need as decision maker. And then we need to get an effectiveness-based answer. I have chosen a very extravagant example because this is about leishmaniasis in Argentina. But it's really clear-cut. We have two different possible decisions: early diagnosis and transmission prevention, and then Monte Carlo simulations were made to inform the decision maker about which solution was the more cost effective. I wouldn't say this is always possible, but this kind of information is what we need. Not only the absolute value of the intervention, but somehow, as we used to do when comparing treatments, a comparison between possible decision alternatives. We need also a context-wise answer. And this is very relevant, I don't think only in a coverage decision. Yesterday, we listened to a very, very interesting and provocative talk about the difference in the implementation of guidelines according to the different needs of the population involved. Guidelines are built on some kind of populations. When we implement guidelines, we confront with maybe, possibly, different population. But when we talk guidelines, clinical guidelines, we know exactly what we mean by different population, by age, by multimorbidity, by sex, by culture, and so on. We should do something similar about the definition of the variables which can affect the implementation of our decision, and in some way include these context variables inside our decision process. And I tried to write down some of these possible variables we should take into account, which are not only the technology available, but also the level of individual skills which are available in the context where we are operating, and then the amount of individual skills. How large is the availability of these skills? And then, which is very difficult to take into account, the quality of the leadership, the characteristics of the organization, and of course, the amount of the available resources. And I think these variables should be considered in the specific setting and should be included in a decision process at the local level. And this also we should, I think, investigate. There is actually, I think, a dual attitude. The change can be resisted and can be accepted, and actually not always the change accepted is the most useful and the most relevant from public health point of view. And we should understand when we decide which are the constraints which are determined by the local situation, which is the attitude towards change, which is not necessarily driven by who have to operate the change. And then, what you mean to assess the quality of the decision. I don't think that the side-driven decisions, can be considered as prescriptions. Just give the decision maker something like a reference point, and the quality of the decision on the large numbers should include a certain degree of variability. Actually, I would say the variability is somehow an indicator of the quality of the desired recommendation. I mean, it would be interesting if we could compare in several different settings what were the recommendation of the side, which were the actual decision made, and to analyze the residuals, to look at the reasons behind the residuals observed, to discriminate between the residuals which are, not damaging the side process, not emphasiating, I would say, not lessening the decide process, and which are the residuals, the variability, which introduced information. There is something which were considered in the decision that which was not considered in the decision, in the decide process. So I think the variability should decrease with time, but it will stay as an instrument to, to understand better the difference between a decision tool and the actual decision process. And finally, we need to assess the impact of the decision on a time interval. This is a story of a success of the Italian health national system when in 1978 it was decided to cover within the health system the voluntary abortion. One of the explicit goals of this coverage was to decrease the rate of voluntary abortion. It was a very sound decision which included an instrument of evaluation. It was at the same time when the decision was taken, it was also decided that the time trend of the abortion in Italy would be strictly monitored. I think it's the only law we have about coverage of health services in Italy in which this kind of evaluation was directly indicated. And what we see in this case is that actually it was a big success. It was a correct decision. We need to have this feedback on the decision we get. So when we take a decision within the tool which help us to take decisions, should be included the criteria through which we are going to monitor the impact of the decision we are taking. Then, how these needs are considered within the side tool as we are using it now. Not bad, I would say. Of course, it helps in identify the relevance of the coverage decision. Why plus minus? Because it is specifically interested in the intrinsic relevance and not so much in the comparative relevance, and it's not clear how to prioritize the coverage decision. So it's not exactly what we need in front of possibly multiple requests, but we have something, and very important. We know if what we are deciding on is really relevant for the population health. As I told before, about the question we ask, we are not in very good shape. We are not defined, strict criteria through which build up the question we want to answer. We are outstanding in the evaluation of the evidence. We are really outstanding. We can do more, of course. We can do more in terms of presentation of the evidences. We can refine, maybe, to make this part of the information granted by the decide tool, more palatable to decision maker. But this is what we have left. But the instrument is very robust. To get a context-wise answer, well, we have part of it. We are attentive to the cost effectiveness, not so much to the specific context variables which could affect the decision we are taking. To assess the quality of the decision and to assess the impact of the decision, I would say we have all the elements inside the tool, because most of these indicators are the same which we use to define effectiveness and to define the relevance of the question, of the coverage question, but we are not yet very clear on the way we are using to include this in the tool. As a summary, if we have on one side the criteria of the side tool, on the left side, and on the right side the need of the decision maker, we have a lot of needs satisfied, but to formulate the question in answerable terms, to assess the quality of the decision and to assess the impact of the decision, we have to work on. So, what do we still lack? Sounding probe for comparing relevance, an algorithm to construe good questions on relevant coverage issues, reliable criteria to assess context variables beside budget constraints, reliable criteria to assess the quality of the decisions, and reliable criteria to assess the impact of the decision. Of course, the side tool, as a daisy, I would say, is always a health technology and should be scrutinized as a health technology in terms of effectiveness, feasibility, and costs. What we are, asking from the intervention, we should ask also from the side tool. And then what we should do on the experience we made, which is up to now a lot of experience to identify problem and to find solution, is to build additional experience, to test in real decision settings. But this was also told by Marina, to make the tool more friendly, to monitor the use, to compare experiences, to assess mode of use, and to compare effectiveness. To draw a sobering summary, we are not yet there, but we are very close. Thank you very much.
Thank you, Carlo. So I will give the floor to Francesco Nonino, who is involved in the Regione Emilia-Romagna, in the regulatory agency, the local agency for drugs. He has prepared the talk together with Nicola Magrini, who is now at WHO with the essential medicine list, could not join us today. And Francesco, please, if you manage to stay in 20 minutes, we can have some.
So good morning, everybody, and thanks to the organizers for giving me this opportunity of sharing with you some considerations that I would like to make very practical. I'm particularly excited and interested in how to turn theory into practice, so I will share with you some consideration based on experiences in the real world. I am a member of the GRADE working group. I work for a public healthcare system in Italy, and most projects I'm involved in are aimed at optimizing the use of public resources, also financial, in drug utilization. So this is the field I know better, and I have no personal income for profit income in this sense. Before getting specific, I give you a very, very quick overview of how our National Health Service works, also because I'm aware that across Europe, national healthcare is provided in different ways. So in Italy, we have a public system where healthcare is provided to all citizens and basing on a public healthcare fund coverage. Equity is warranted by a list of essential levels of health care. And Italy is divided into 20 regions. Each one of them has some kind of autonomy in delivering health care, so that each one has its own healthcare fund. Regarding drugs, the national coverage decision is made at a central level by the National Drug Agency, the IFA, that operates through basically a two-step process. When the European Medicine Agency registers a new drug, our Drug National Agency submits it to a technical scientific board that decides if the appropriate prescription needs to be monitored through making registries, identifying patient subgroups, and limitation notes for appropriate use of the drugs, and so on. And a report from this board is then submitted to the pricing and coverage board that basically performs the price negotiation. So through considering different types of issues, financial impact, consideration of other prices in other European countries, comparisons with products with similar efficacy, and so on, comes out with a decision, drug not covered or drug covered nationally. For covered drugs, nevertheless, each regional healthcare system has still some freedom in coverage decisions. How? In different ways. There's a kind of a variability among Italian regions in this sense, but these are the tools that regions use to make coverage decisions locally through drug and therapeutics committees, commissions, making wise lists of drugs, by specific programs of information on drugs, by producing guidelines, by procurement procedures with drugs that have identical efficacy, similar efficacy, and by monitoring, especially by monitoring drug utilization in the end. How? Normally, coverage is restricted locally by limiting the prescription of drugs only to authorized specialist centers through the therapeutic plan. This is a literal translation from Italian, piano terapeutico. It's basically a form that only specialist centers can provide in order to have the drug prescribed to the patient, and monitoring the prescription through indicators that basically in this case are expected prescription rates, and also through projects of audit and feedback involving prescribers, but also other stakeholders like pharmacists and hospital managers and directors. So specifically, we as a Work Package 2, we tested the DECIDE tool in different regional drug and therapeutic committees, mainly in the Lazio region and in the Emilia-Romagna region. Specifically, my region where I work, the Emilia-Romagna region, adopts an explicit drug coverage policy that implies a broad involvement of prescribers in coverage decisions. It's basing on a robust methodology, grade methodology, that is necessary to, in our view, to be reliable and credible for effectively implement and monitor the recommendation we make. At the same time, guaranteeing some flexibility that clinicians are always very fond of when they think about their clinical decisions in specific subgroup of patients. What I mean by broad involvement of prescribers is that our Drug and Therapeutic Commission works very closely to specific work groups, specialty focused. This is a list of the work groups we are they are active right now. Emilia-Romagna region is a 4 million people region. So although there are many stakeholders involved, there's still people who don't make coverage decisions in Emilia-Romagna. And the way we tested the DECIDE tool in the Drug and Therapeutic Committee's work groups was through making some frameworks using the DECIDE tool. We did 4 of them. We made 4 of them, 2 about diagnostics, 2 about therapeutics. And we used one of the therapeutics, the frameworks about therapeutics, specifically about the new anticoagulant, the bigatran, for patients with atrial fibrillations. And we submitted it to the committee, to the work group who made a regional guideline containing basically recommendations on which patients mostly benefit from the bigatran instead of warfarin. So we translated the framework in Italian, and we got feedback from the users of the framework during the production of these therapeutic recommendations. What we learned from this experience was that generally the DECIDE tool is well accepted and welcomed by panelists, although they generally are not used to such a structured framework. So we learned that we need to take our time to explain clearly, take nothing for granted when we use this tool with clinicians. It works better in stable panels that consistently work on decision making. And so panelists get used to the tool and understand it better in time. And one other thing is that at local levels, specific recommendations for subgroup of patients are more likely to be done rather than a yes or no coverage decision. And in this sense, the format we have right now that, as we said yesterday, includes yes coverage, no coverage, and also some in-between conditional coverage decision. This type of format suits very well at a local level. And also, we found that it's very important to define indicators. In this case, our indicators are related to the prescription of drugs, and they express basically the expected rates of adoption of the recommendations we produce. I take a very short break to show you what I mean by this. While making this other guideline on the appropriate use of new drugs for diabetes with one of those work groups I showed you before, we found out that we used the GRADE methodology to produce the recommendations, and we found out that in order to have clinicians, decision makers, let's call them like that, more aware of the meaning of the language we use, which is in this case, what does it mean, a strong positive, a weak positive, what does this mean? On top of a wordly definition, also associating an expected adoption rate, a number that defines what we expect that adopting this recommendation implies, is very useful and I must say also reassuring for decision makers. So this is an example of the format of our recommendation that includes quality of evidence, benefit-risk balance, and always an indicator with a numerical expected rate, which is clearly explained in the guideline, like what is the denominator, what is the numerator. Of course, the effort we make is to build up an indicator that is very easily monitored in time, because this needs to be routine. This is not a specific project that we do for experimental purposes, but it's got to be in the future the routine of monitoring these coverage decisions at a local level. So I think, thinking about specifically about our actual framework, the format of our framework, DECIDE frameworks for coverage decisions, I think that DECIDE users should be in panels, should be encouraged in being specific when talking about monitoring and evaluations consideration. This field, which is towards the end of our framework, I think we should encourage panelists to be specific about indicators, monitoring indicators that should go, I think, right here. One other message we got from this experience is that passive online questionnaires to get feedback are not very useful. So we got very low response rates, so we need to be more proactive in getting feedback. And so the yes-no coverage decision is only one part of the spectrum of decisions, although coverage decision at a local level may be strongly influenced or even limited by central coverage rules. If we are talking about a healthcare system like the one we have in Italy, where, you know, as I said before, there is a central coverage decision. I think that this information is important. This context-specific information is important. It should go also in one of these two, specified in one of these two domains of our DECIDE framework, the acceptability or feasibility. It's an issue that I think should go somewhere here when it's present. In summary, I think that local coverage decision may best benefit from the DECIDE tool if they are part of a structured governance policy. This sounds obvious, but I think it's always important to bear it in mind. And especially if we try to implement an disinvestment policy involving clinicians in this kind of decision making. And recommendations should always go together with indicators that are very important, I think, if we want to translate theory into practice, if we want our theory to have a relevant impact on the quality of healthcare. And indicators should be used inside a structured monitoring plan, which means expected uptake rate of the recommendation. In this case, we talk about drugs, so it's like it's an expected prescription rate, but it could be also diagnostic uptake, also applied to other fields. And it has to be shared and pre-specified and shared with the future users, with the decision makers. So what we're going to do in our agenda, we have some ongoing projects that Marina was mentioning before. We have two posters, one about an ongoing project on coverage decisions about vaccinations, another one about regarding coverage decisions on non-drug, non-therapeutic issues, diagnostic technology, and surgical devices. We will do more testing in practice, in real life, in coverage decision-making panels, more in local drug and therapeutic committees. We are planning to prepare a few frameworks to submit to the WHO Essential Medicine list. Next meeting is in April 2015, so that could be a good chance of getting a feedback from an international board making coverage decisions. Now, Dr. Magrini is part of it, so this will help us. And we need to test it also on local committees making coverage decision on technologies that are different from drugs. As I said before, we need to be more proactive in getting our feedback from DECIDE's users, the DECIDE tool users, and we need to improve. This is a challenge, I think, to improve our ability to measure the true impact, the net benefit of using the DECIDE tools on decision making. Thank you very much.
Thank you, Francesco. So I think we have time for some questions.
Can I take it from here? Yes. Yeah. There's also, I'm Frode Forland from Norway, working at the Public Health Institute. And my comment was actually elicited by the first talk by Carlo Saito, which I think mentioned a lot of relevant comments on the context sensitivity issue. And I think it's, when it comes to finally taking the decision, it's almost everything is about context. There is something first, which is about content, where we are pretty good. And then there is a lot afterwards about context, where we've been so far, I think, in a kind of number of gray boxes that the DECIDE tool is helping us to open up. And I think they are helping us to try and find ways of evaluating those soft elements of the guideline developing process in a good way. At the same time, it might look now like it's becoming so complicated to open all those boxes that it's only those who have been part of the Framework 7 program who can do that work according to the rules and settings this instrument is offering. Because I think we still need a lot of people having the skills of making these decisions as evidence-based as possible. And my question is actually to say, how can we still keep this spirit of making guidelines with the rigor needed by these instruments that have been developed through DECIDE, and also keeping this at the practical level so that people can be able to do it when decisions have to be taken quickly and when there is lack of evidence, but decisions are still important. And also I have a question which is maybe more to the DECIDE team themselves. Have these policy issues now and the coverage questions been considered regarding low and middle income countries and how to make decisions in such a setting? Thank you.
Yes, I think we should increase our ability to cope with those kind of problems just applying the DECIDE tool. You know, we should apply the DECIDE tool not thinking to have a perfect tool before applying it, but we should have, you know, very, very present in our mind that when we look at the results, part of the variability we find in the results in terms of decision taken and even decision implemented after being taken, then may be part of the reason is that the decision should have been more, you know, defined in the context. So I think of the DECIDE tool as a dynamic tool that we have to implement and to improve through experience. So there is no actual contradiction between the need, you know, to get it fast and the need to have it applied and the need to have it constantly improved. So I think we can come out of the project with a very good decision tool, and then our work is not finished. I think one of the most relevant, collateral utility of a decision tool is to be somehow consigned to the utilizer and fertilize the way the utilizer build up their decision process. And there is a, directional exchange. And I think this is part of the process we are activating. Not to consider this aspect now, I think could be somehow to say we are giving you the best. I think what we can honestly say is we are giving you an instrument that will consent you to improve your decision capability. And if we can get to that, we'll get an extraordinary result.
I may add something on the second part of the question, and I think there will be more on this about the Work Package 5 on health system policy decision, and particularly on the low-income countries. And the WHO that is participating to the overall project is particularly involved in this part of the application, so for both coverage and health system decisions. So there is something more. Other questions? Yes.
Sorry, this will be the last time, I promise, right? And I wanted to do this like Larry had said, because he was talking about a story. And I was sitting in my kitchen, and my Labradors just had 10 puppies. And I was trying to sort of cognitively heal myself from the fact that they turned the kitchen into a toilet. So I was listening to Women's Hour. And Women's Hour, they were talking about urinary incontinence. And I was listening to your talk, and I thought you could apply the PICO model to urinary incontinence, in the sense that you have a population, and this is women who have had babies, and the problem is a severe problem in that urinary incontinence, and although not regarded as a particularly sexy subject by doctors, it's an incredibly disabling problem for women who have it. And the index treatment that they were sort of like, that they were talking about was pelvic floor exercises, which of course are very badly done in the UK anyway. And the whole program was concentrating on the fact that most women were not able to get access to how to do these exercises. And on top of that, a lot of them, even when they thought they were doing them right, weren't doing them properly. And then there are the sort of comparative treatments, which would be, you could use duloxetine, I suppose, which I think tightens up your urethral sphincter a little bit, but I don't think the evidence is particularly good for that. And then, of course, there's surgery, which is effective in managing urinary incontinence, but on the other hand, it's very invasive and it's quite difficult. And they talked about France, and I don't want to denigrate France at all, but France, during antenatal care, all women are given kind of dildo-type things that they are taught on how to strengthen their vaginal muscles. Now, in the UK, this would be difficult because we get uncomfortable once you get below the umbilicus. But the fact of it is that this is a highly effective treatment, and the outcomes of good pelvic exercises basically cure and prevent urinary incontinence. And the thing I find amazing about that is that probably we knew that 30 years ago, and yet we've still got a Radio 4 program today. Why haven't we managed to put that into action? Why haven't we in the UK managed to have a comprehensive service that ensures that no woman ever again after childbirth suffers from urinary incontinence? And I just thought you could apply this PICO system here really well to that. It's much cheaper than the current option in the UK, which is really to wait until you're incontinent and then go for surgery. And it just would improve people's lives again. Sorry, I will never speak again.
So I find this question very interesting, really very interesting, because when I was trying to speak of a public health-driven agenda. I was just saying this. We don't need to evaluate a new, extravagant surgical procedure on incontinence. We need to know what to cover and at which conditions, which is exactly what we are trying to, build up. There is public health-driven agenda and includes incontinence. There are different treatment. We cannot say some of those treatments cannot be covered as far as they are effective. But we can say, okay, but within the coverage which we grant, there are some specific interventions which are more cost-effective, which should be stressed, which should be promoted, which should be included in good coverage of what we are giving to our population. It's just exactly when I was not, the robot da Vinci to do the extravagant, very specific surgery, but procedure, intervention, which are effective and should be effectively covered.
So, well, thanks. So I think we've got to the end of the session. So a couple of housekeeping advices from Sean before thanking the speakers. And one is, I think we have the workshop now, and people that are going to the evidence to decision framework workshop, please, if you could take a laptop with you. It's important to do the workshop itself. And then there is lunch right after the workshop, and we get back here, what time? 2 o'clock. 2 o'clock back here for the first session of the afternoon. So thanks again to the speakers and to the audience for questions and listening. Thanks.
Okay, good morning, everybody. Thank you for getting up that extra bit early this morning to let us fit in today's crowded programme. Just before we get underway, there's the usual selection of administrative things to sort out. Everybody got one of these in your conference pack. This is something which has just been launched in Edinburgh, and they're very keen on getting some feedback. So if you've used this card at all and you have any feedback, either good or bad, if you could leave a note or whatever with reception just saying how you found it, that would be very helpful. Yesterday we had a few people saying there's an awful lot of initials and acronyms appeared in some of the presentations. So could I ask all the speakers, both at the plenaries and at the workshops, that if there are initials and abbreviations in your slides, if you could take care to explain what they mean, bearing in mind that we do have an international audience, and acronyms which are very familiar to us in the UK, for example, maybe don't mean so much to people from the Scandinavia or other parts of Europe. And an announcement specifically for the people from NICE who have an extra session arranged at lunchtime today. That session will take place in the new library, which if you haven't found it already, somebody will direct you to. Lunch is provided in that room, so you don't need to get your lunch and then go to the session. You can just go straight to the new library at lunchtime at 1 o'clock. When it comes to workshops, we are not going to provide guidance from this room. We are going to hope that most of you learned to lay out the building yesterday and you can make your own way to the room where your workshops are. The helpers will still be dotted around the building with their yellow badges, so if you need any help or advice on how to find the room that you're wanting to go to, if you ask one of them, they should be able to point you in the right direction. I think well, that's the end of our commercial, so now we can get down to this morning's business. The session yesterday ended with people talking about shared decision making and how to communicate between the healthcare workers and patients in that particular clinical encounter. What we want to do this morning is to look at communication in a broader sense, in that patients often look for information out with the clinical encounter where they want to find out what they can about the condition they have, what the options are available for treatment, and for some of them also to find out what they should be getting. I mean, if I've got this condition, what should my health care provider be offering to me in terms of treatment options? So thinking in that broader context about how we communicate evidence to people. Excuse me. We're also focused at Indecide, we're focused very much on guidelines. And if you look at the web or any other source for information, you will find there is lots of advice out there, and guidelines are only one source of advice that people have. So one question we have to think about is what do we don't have? What's our unique selling point, which makes guidelines the option that people should go for? And it is obviously about evidence, and it's how you convey the importance of evidence-based decisions to people. And in some of the research that we've done, we found that there are issues in that people are often quite surprised and sometimes even get quite hostile about the fact that research is not always good, or some research is better than others. People have a tendency to assume that if you've done research, you have an answer and that's what you should do. And getting across the idea that some research is better than others is not always easy. So these are some of the issues that we need to think about. And the plan for this session is mostly that you're going to tell us how we should do this, right? But before we do that, we have a panel of these people who are going to speak briefly from their own areas of specialisation to give us some ideas to start the debate off. I think I have to say that the first thing, a bit of advice for communicating with people through the media is don't rely on high-profile media correspondents, because they're prone to get called away on some urgent story and leave you high and dry at the last minute. So unfortunately, we do not have the BBC's health correspondent with us today. But I have to say a very big thanks to Helen Tyrrell here on my left, who has agreed to stand in at the last minute. I accidentally gave Helen a doctorate in the programme, which apparently she doesn't actually have. But she comes from a public health background and has been involved for a number of years with the voluntary sector in healthcare, and has acted as a patient advocate in that capacity quite often. On my right, we have two speakers who I'll introduce one at a time, as they're going to speak to us first this morning. And first of all, I'd like to introduce Dr. Karen Facey, who trained as a statistician and worked in the pharmaceutical industry and medicines regulation before she came to Scotland to lead what was then the Health Technology Board for Scotland. And that organisation sought to encourage meaningful patient participation, from scoping work right through to communicating its results. An experience that she gained there sort of motivated Karen to go on to lead the HTA International Interest Group on patient citizen involvement for about 7 years, which developed a number of tools and frameworks to support patient involvement. So she now works in partnership with a lot of stakeholders to ensure that there's good communication with patients and patient organisations to help them contribute effectively to health policy decision making. So if I could ask Karen now to give your presentation.
Thanks, Robin. It's a pleasure to be with you here this morning in Edinburgh. And the programme talks about using media to communicate evidence to the patients. And I'm going to kind of use that in the broadest sense because I'm really interested in how we communicate with patients in general. And as Robin has indicated, I know yesterday you had some about the kind of clinician-patient relationship, but I'd like to think more broadly than that. And what I'm going to do is bring you some of my experience of the issues we faced in medicines assessment, or what we sometimes call health technology assessment, HTA there. I'm going to think about what patients might need from evidence, and I'm going to particularly focus on the role of patient groups in communicating evidence and how they might act as a conduit with their members and the wider patient community. Within medicines assessment, we don't ever worry about whether the media will pick up our assessments because all too often they do. So here in Scotland, 3 patients from very rare diseases made petitions to Parliament. This led to a complete review of the way medicines were assessed in Scotland, and this is one of the headlines that came up during the review. So it's actually indicating that a medicine's assessment for a prostate cancer drug, but actually it wasn't being enacted, and why was that the case? And for those of you in the UK, you will know that NICE, the National Institute for Health and Clinical Excellence, is quite often in the media, and we quite often hear clinicians and patients talking about their views of that assessment. So we have some experience of dealing with the media. But I'm interested in knowing what do patients need to know and what's their experience. And I've been always influenced by Sir Ian Kennedy. For those of you in the UK, you may remember there was a major scandal in our children's hospital services in Bristol where more children were dying than should have been on the operating table. And it took us far too long to identify that there was an excess mortality. Sir Ian Kennedy was asked to do a review, and in that he recognised that there are 2 forms of experts, and the patient is one of those. And he captured the expert-patient phrase, recognising there are at least 2 bodies of knowledge that are relevant to the exchange between a doctor and a patient, the doctors and the patients. Both are experts in their own fields. The doctor in clinical matters, the patients in his or her experiences, feelings, fears, hopes and desires. That was back in 1999, and it was at a time where we were perhaps already seeing that in some long-term conditions we recognise patients as being experts, particularly in relation to diabetes. The word expert patient was coming through. But that's a kind of sweeping statement there. So patients are experts in their own feelings, experiences, views. But what we need to remember is that patients are all different. And here I present a slide from Anne Single, who was our Director of Patient and Public Involvement in the Health Technology Board for Scotland. And we need to recognise that patients aren't an amorphous group, they are individuals. So how do we communicate in an appropriate way? They have different expectations, interests and experience. Some may have different genetic aspects which affect their outcomes, but they have beliefs, they have community issues which may be to do with location or religion or other issues. Important things to consider in relation to communication is also the bottom one, which is around health literacy. And as I do my work around Europe at the moment, there's a lot of discussion about health literacy. So are patients able to understand what we're trying to communicate them, and how do we communicate in a way which they can understand? Well, Sir Ian Kennedy made that statement in 1999. If we sort of roll on a decade, the European Council, through WHO, was looking at empowerment of patients and seeing that as being an absolute prerequisite for health. and that actually what we need to do is encourage proactive partnership and patient self-care, or what we would call self-management, to improve health outcomes. And they recognise within that statement of the need to empower patients that patient groups are crucial to support individuals living with the disease, and in terms of the collective work they can undertake to improve patient conditions. And patient groups play a very key role in understanding how they can communicate with the variety of their patients, with their individuals. I do a lot of work with patient groups internationally, with international umbrella organisations, and I just thought I'd share with you some of the insights that I've seen as I work with them. If I was to look at the media, I would think that patients are only interested in new medicines, because that's all I see in the media. When I work with patient groups, what I realise is actually these are committed, intelligent individuals who actually want to improve the whole pathway of care for their patients. They want to understand what is high-quality care, and they want to understand treatment choices. They don't just want any new expensive medicine. They want a medicine that is effective, and they want a medicine where they can understand what the risks and benefits are. So they want to enter into that dialogue given their own situation. And if they can be informed about what is high-quality care, they would then like to play a role in ensuring that that high-quality care happens right across their region or their country. Patient groups can play a really important role in helping us understand where there is variation in practice. And for those of us who work in quality improvement, we know that reducing variation in practice and reducing harm is key, and patients have a key role to play in that. But they have to understand evidence-based high-quality care. And they can then use this information to resource and train other patients. And for me, that understanding of what is high-quality care comes best when patients and patient groups have been involved in the development of guidelines. And I know that, for example, GIN, the Guideline International Network, has created a great toolkit to help guideline developers engage patients, and we want to see more of that. And what we want to see is patient engagement from selection of topic through not only to reporting, but to dissemination. And I think that we don't talk enough how we disseminate guidelines with particularly the help of patient groups. And if we think about what patients want to know, some of you may know Hilda Bastian, who was very strong in the Cochrane Consumer Network, then went to work for IQVIG, the HTA organisation in Germany, and they actually had a patient database for evidence-based guidelines. But they wanted to kind of prioritise what they were going to put on this database, so they kind of did a survey, and they had 124 Cochrane reviews, and they issued this survey and got 194 responses. I have to say half were from healthcare professionals and half from patient group members, half from Germany and half were international. And from these 124 reviews, only 8% of respondents found that the statements that were made in these Cochrane reviews were significantly interesting. And actually half the statements were significantly uninteresting. And for those of us who are guideline developers, you may know that quite often we say there is insufficient evidence. Actually, that's not of interest to a patient. Patients really aren't interested in that kind of information. And not surprisingly, the 8% of interesting statements were the ones where there was good evidence about a condition, and you were actually saying, we recommend a treatment. And so that's a challenge for us, I think, where we have sparse evidence. And I think the key for Hilda and her group was she had a website, but actually if we talk to patient groups now and if we talk to patients, we recognise that patients don't go to the SIGN website or to their own guideline website or even the Cochrane website to find out information. They just Google. And when they Google, they find all sorts of information. I almost said rubbish there. And this is where patients are getting their information from. And they find it challenging to identify what is good evidence and how do they sift through that evidence. It's a real challenge. Where patient groups can play a role is to link with evidence-based organisations to disseminate good quality information through emails and newsletters, and that is increasing. We're also seeing blogs used by individual advocates as being important. Facebook and Twitter, obviously. Discussion fora, we're seeing patients like me, etc. These kind of areas where patients are sharing their experiences are becoming more and more influential. And of course, we see patients seeking to lobby Parliament. As I say, a few patients may come to the signed guideline, but they would want to see a kind of summary, I guess, not the large guideline. And I'm fascinated by how there has been a development of so-called plain English summaries. You'll have your own equivalents, but kind of simplified summaries in your own language. And in the UK, the National Institutes for Health Research has just indicated that research proposals will not be accepted unless they have a plain English summary of the research as proposed. But they're not yet being very forceful on how research is communicated when it's finished. And I think that is the key element. And what we need to be doing is producing summaries that can link into all of these ways which patients are using to communicate with their members. And if we look more broadly across Europe, there are increasing so-called patient universities. So there's a Spanish patient forum led by a clinical oncologist. There's the Italian Patient Academy, which I teach on. There are international patient organisations. So I've just come back from the International Organisation for Neuroendocrine Cancer. I also work with pancreatic and sarcoma patients. There are also umbrella organisations in one country, and Helen will tell us a bit more about the work here in Scotland, no doubt. So how do we link in with these influential areas that are, in a sense, umbrella organisations or patient academies to influence them? In the National Institutes for Health Research funds Involve, which is an amazing organisation. I just don't think we in the UK recognise how lucky patients and the public are in terms of their resourcing. So they have this kind of resource library. This is their website. You'll see they've got an evidence library. And they produce a great bibliography of interesting references. So my question to Sign and NICE would be, so how do you link in with that? Is there any way we can develop that? And if Involve are currently doing a major strategic review, is this something that could be considered in that strategic review? I'm involved in EUPATI, the European Patients Academy on Therapeutic Innovation, which is a partnership between the European Parliament Initiative and the European Federation of Pharmaceutical Industries Association. So this is really working with patients groups. It's led by the European Patient Forum, and its goal is to inform patients about medicines development, regulation and assessment. So it's really helping them understand the basis for some of our decisions. And it's fascinating to me that this course stops at the point of assessment and doesn't discuss how clinical guidelines are developed. What it's doing is developing 100 patient advocates. These are going through almost diploma-style learning about preclinical, clinical, and post-marketing of clinical trials, regulation and assessment. They're then seeking to, in a sense, use those ambassadors to then communicate with a wider pool of patient advocates, and then create a library. And I think that's quite an interesting model, where you have so-called, perhaps, patient communication champions could be a role within Decide, and you kind of roll out and recognise that people have different knowledge needs. Those that are interacting at European Parliament level need to be expert and need to have different training and communication than perhaps the general public down at the bottom there. And what I'm reflecting on is a patient who said to me last year, I think it was a pancreatic patient, said to me, I wish I had found the sign guideline earlier. It's a marvellous resource for me and my organisation. It tells me what high quality care is. Because organisations, it is treatments they're interested in, but actually one of the most important things they're interested in is diagnosis. Because particularly in the area of cancer, so many diagnoses are late, and patients want to help clinicians and the general public in terms of awareness around diagnosis and earlier access to clinicians to get those diagnostic tests. And as I say, we're never out of the press. So here's a recent extract from our Scottish paper, The Herald, on the 12th of March. And here we're reporting a new MS drug. And this is, I think, a pretty clear representation. So I think the media are doing a good job here about a new MS treatment. And it's the first oral treatment available for this important disease. And at that point, I'm going to hand over, I think, to Anna.
Well, thanks very much, Karen. I think since we hope to have quite an extensive discussion at the end of this, we'll save questions or comments till all the speakers have finished. So now I'd like to ask Anna Sayburn to present. Anna has a background as a consumer journalist, and she's currently head of consumer health with BMJ Publishing. So, Anna, you want to...
Thank you. So, acronyms first. BMJ, British Medical Journal. One of the well-kept secrets about BMJ is that we don't just produce the journal. We produce a lot of journals. We also produce a lot of decision support information for clinicians. And even better kept secret is that we produce consumer health information. And that's what my team does. So that includes a website called Best Health, where we talk about evidence-based information about treatments and diagnosis and prognosis and all of the things that you would see in our decision support tools for clinicians, such as best practice and clinical evidence. We use that evidence and we try format so that we can explain it directly to patients. We also do patient information leaflets which go with our clinical products. So if you have best practice, you also have the patient information leaflets. And over the last 2 or 3 years, we've been creating patient decision aids for the NHS. So we have a fairly broad range of patient information products, which means that I've got a fair background in creating evidence-based information for patients from clinical evidence. So the first question really, what does the public need to know about clinical guidelines? Well, it's always worth starting off and saying, well, why are we actually bothering to communicate clinical guidelines to the public? Let's have a clear aim about this before we start. Everyone's overwhelmed with information. People are short on time. People are short on attention. Everyone's getting hundreds of emails a day, text messages, Facebook messages, tweets, all the rest of it. Who's got time to hear about clinical guidelines, and who has time to actually create the information to give to people about clinical guidelines? You've worked on these recommendations in your guidelines for months, years, you've sifted the evidence, you've done all the work, you know that these are as good as you can get. Surely the important thing is to get that across to the clinicians and make sure the clinicians are using the recommendations. Do you need to do any more? Why would you bother telling the general public about them as well? So I thought about some reasons. And the first thing is, if you're working in a publicly funded health service, it's actually our money you're recommending that is spent on one treatment over another or one diagnostic test to be introduced. And if it's public money, then we do actually have a right to know what it's being spent on and why you think that it's a good idea for us to spend the money in this way. The other thing is, as Karen's already said, the public actually affects healthcare priorities through media, through politics, through pressure groups. The public is already setting the agenda. If you want your guidelines to be implemented, and specifically if you want them to be funded, then you do have to have a level of public support. I was thinking about, for example, the Cancer Drugs Fund, which was introduced I can't remember how many years ago now, not because there was pressure from clinicians, not because there was a guideline saying that this should be happening, but because there was public pressure that cancer patients weren't getting the drugs that they wanted, that they thought that they should have access to. So this fund was set up by the government for political reasons, really. And that no doubt will have diverted money away from other, perhaps more evidence-based interventions that could otherwise have been funded. So I don't think we can ignore the importance of the public's impact on how public money is spent on healthcare. The other thing is, if you don't tell people what's happening, what's proposed in your guidelines, what your recommendations are, then someone else will. And you might not like the way that they do it. And I was thinking about here the Liverpool Care Pathway, which I hadn't heard of, and probably most people hadn't heard of, stories in the national press. And they weren't flattering. They were stories about people's relatives who said this appalling thing happened to my relative, my elderly relative who was in hospital, and they put them on this thing called the Liverpool Care Pathway, which meant that they had all of their nutrition withdrawn. It was dreadful. It's a death pathway. And this was the name that it started to get. Now, I'm sure that the people who set up the Liverpool Care Pathway, without wanting to go into the rights and wrongs of it, because it's a very complex issue, did it for all of the right reasons, had assessed all of the evidence, but what they hadn't done was explained what was happening to the general public. Nobody really knew about this until you started to get these horrible, negative, very emotional stories in the media about it. And the Liverpool Care Pathway was basically ditched as a result of media pressure and public pressure. Because the clinicians, the evidence community had kind of lost control of that discussion. They'd not set the parameters. They'd not started by explaining, this is what we're doing and this is why we're doing it. It was all very reactive to what became a very toxic situation. Because at base, I mean, people want the system that they're being treated in. They want the system to be fair. And if you think back to 1995 was about when I started working in healthcare journalism. And the buzzword at the time was postcode prescribing. And what people were really agitated by then was that people in one healthcare area were getting funding for a particular treatment, whereas other people couldn't get it. So if you were this side of the boundary, then you could be treated, and if you were this side, you weren't. And people saw it was basically very unfair. It's one of the reasons that the Labour government set up the National Institute for Health and Clinical Excellence, as it was then. And it was seen initially, I think, as a very good thing that we were going to have people actually making decisions for the whole country, England and Wales at any rate, and the decisions would be based on a fair assessment of the evidence, and that would apply to everybody. We would have a level playing field. The agenda seems to have been, again, slightly lost perhaps, and maybe some of that was to do with some of the more controversial decisions that NICE needed to make in its early days and the way that those decisions were communicated. But at base, I think people do want to have what they understand to be a fair system, and they won't understand it to be a fair system unless the reasons for the recommendations have been properly explained. Because what we do know is that people will resist change, particularly if they're being told that they can no longer have something that they previously had, or that something is going to be made more difficult for them or less convenient or whatever. So unless the guidelines that you're introducing are saying everything is staying exactly the same, then you probably will come up against some level of resistance at some point. Right at the beginning is your opportunity to explain to people why you're doing this, what the reasons are, what the benefits for. And that's the opportunity you have to get people on side. So, reasons for explaining guidelines to the general public. You want to have them implemented, you want to have them used. If they're not carefully communicated and explained, then they may be resisted or even blocked if that's not got right. So we've talked about why you should care about explaining guidelines to patients. And let's just flip this over a minute and think, well, why should the public care about your guideline? I was out of the office for a couple of days. I came back, I had 100 emails a day. I'm not going to read them all, obviously. I hope my colleagues will forgive me for that. So the first question you're always going to ask is, do I need to know this? Is this important to me? And that's always going to be the first question. So you've got to be very clear when you're communicating about your guideline, who is actually affected by this. If you think about your email inbox, one of the first things I check is who else has been sent this email. If it's everybody on my evidence-based medicine mail list, that's not going to be a priority for me to read and answer. If it's everybody at the BMJ, that's probably not going to be a priority either. If it's just me, if the address is Anna Saban, then someone specifically wants my attention. They've got something to say to me. The next thing people want to know is, well, what is it that's changing? If you're saying it affects me, what is it that your recommendations say, and what's changing from what I already know? If that ticks their box, then, okay, so how's it going to affect me? What am I actually going to notice? When's it going to happen? When's it going to start? And then, absolutely crucially, why? Why is this happening? Why are there going to be changes to the way that I experience my care? And those, I think, are the key questions that we need to get right. So those are the questions that I'm going to focus on next. And the who question is absolutely critical. Know your audience, who you're actually talking to. So you need to think about the patient group that you're addressing, adult patients, elderly, adolescents, child patients, in which case actually are you trying to communicate mainly with the parents of child patients? You may be, you may not be. You may be wanting to communicate directly with the children. Is it actually carers who are going to be most affected by this? Then there's a whole heap of other things you need to consider, which Karen's touched on. So language, not just am I writing plain language, but am I writing this in the correct language? Is it English, or should it be another language altogether? You know, who is it? Do I need to think about translation? Who is it who's going to be using this, and what sort of language do they need? What literacy levels do they have? When we're writing for Best Health for our website, because it is aimed at absolutely anybody who accesses our information, we aim for a fairly low literacy level of around, it's about between 8 and 12 year reading age. So 8 to 12 years reading age is about the average for the UK, although there are questions about the specifics of it. So you're talking about the plain language rules, which are short sentences of around about 20 words. You use the active tense. You don't talk about evidence has been found that. You say, we found evidence that. You put it in the most simple way possible. You avoid jargon. You avoid acronyms. You explain any clinical terms. You need to think about numeracy. Numeracy is even worse than literacy, certainly in the UK. I have some sympathy with this because I'm much more a word person than a number person. And although, you know, I am perfectly numerate, I remember looking at a piece of evidence where someone was saying, you know, the chance of side effects is 1 in 20. And I thought, oh, that's awfully high, 1 in 20. And I went back and looked at the original paper, and it said 5%. I thought, well, It isn't, it's only 5%. And then I thought, no, hang on. That's exactly the same. And I sometimes show a slide to people when I'm talking to them about how you communicate with numbers. 0.5, 5%, 1 in 20. Which risk are you most happy to take? And quite a lot of people will say, well, 0.5 is the lowest risk. And these are people who work in healthcare and in evidence, so that's a bit scary. So think a lot about how you communicate numbers to patients. Best practice is to use natural frequencies. So things like 1 in 100 people like you experience side effects. 2 in 100, whatever. So finding a common denominator, continuing to use that denominator so people can see what the standard is. You also need to think about what format you're going to put the information out in. Is it going to be printed information? And if so, how are you going to get that printed information into the hands of the people you want to see it? Is it going to be online? In which case, how are they going to find it? Does your population have web access at all? Actually, are you working with a group that has visual impairments, in which case you might need to think about, does this need to be audio information? So there are lots of different things to consider about your audience, and all of these things are going to affect the way that you need to communicate. Then we get to the what, and what changes is, I think, the key question. Just thinking back to my email with my email inbox with 100 emails in it, probably 200 by the time I get back tomorrow. Once I've checked who it's been sent to, I'm going to check what's in the subject line. And I remember a couple of years ago getting an email, all BMJ, subject line, changes to the procurement process for catering services at BMA House. Right, okay. I don't really need to know about changes to the procurement process for catering services at BMA House. What I really do want to know is, does that mean you're changing who's doing the catering? So the menu might be different. I might not be able to get my fish and chips on a Friday, because that's important. I want to know, will I still be able to get my fish and chips on a Friday? Will I still be able to get them from the canteen? Have I got to go off-site? Have I got to order them in advance? Is it still going to be the same nice, cheery lady doling out the chips? Or has she been given the push, and have I got to go and find my chips somewhere else? Is it still going to be in BMA House? Have the prices gone up? Is it, these are the questions that I want to know. I don't want to know how you procured the catering services. I want to know how it's going to affect me. And I think that's the way that you need to think about your guideline. For a member of the public who may be using your services, what changes? What's going to make a difference to them? And in thinking about that, as far as possible, how is it actually going to affect the patient personally? And you need to think, obviously, about patient-relevant disease outcomes. So you're talking about the impact on their risk of having a heart attack or stroke, not the impact on their cholesterol level or their HbA1c level. Think about treatment burden. It's something that it seems to me clinicians sometimes downgrade a bit. They don't realise necessarily that for someone who's already taken half a dozen medicines, taking yet another one that you've got to take at a different time of the day is actually quite a big deal. Or having to come once a month for blood monitoring or for a checkup or whatever. It all makes it harder for you to run your life the way that you want to run it. How's it going to impact on my lifestyle? Am I going to have to change my diet? These are things that clinicians aren't always good at thinking about from the patient perspective, because they do have a really big impact. And if you don't think about them, the patient will. And if they don't like it, they just won't take it. I mean, this is one of the things that I've always talked to people about with patient information. If you ignore the side effects or the likelihood of side effects, but the patient gets a side effect, they're not going to come back necessarily and say, oh, I see that I had a 1 in 20 chance of getting this and I've now got it and I'm not happy and what else. They're just going to stop taking the drug. So side effects, complications, all of these things are important. And I think it is important as well to talk about your chances of getting it, your level of risk, because your level of risk, your acceptance of risk may be completely different to a patient's acceptance of risk. I said this 5% thing. 5% sounds like a fairly small risk to me, but if it's of a major outcome, then it's not a small risk. And for someone else, they might have a completely different perception of that risk. They might think, well, any chance of this thing happening to me is too big a chance, and I'm not going to take it. So it's one of those things that you need to think about. You need to share what are the impacts likely to be on the patient of side effects and complications. Next question is when, and it's partly about, for the patient, well, when will the changes come into force? How urgent is this information? If you leave the communication with the patients too late, then you're going to lose the chance to get the patient on board. I've had to think about this because too soon patients may get confused or forget when the changes are coming in. Well, possibly, but there is such a thing as too soon, because ideally you're not communicating to the patient at the end of the process. The patients, certainly their patient representatives, have been involved all along. They've been telling you what are the things that are important to patients about treatment burden, about complications, about location of treatment, so you already know this. If you've got them involved up front, you know what's important to them. An organisation, a state that will remain nameless, recently approached us to say they had just completed a whole tranche of clinical guidelines and would we write patient versions of them? I said, well, yeah, we can do that. That's fine, no problem. Can we talk to the patient representatives who were involved in it so we can get their take on it? Blank. What patient representative? No, we give you the guidelines and you just write a simple version for patients. Okay, you haven't involved patients yet. No. That's a shame. That's a missed opportunity. The key question is why. Why have you done this? And if you don't explain why, people nearly always, at least in the UK, because we're all terribly cynical, will assume that the guideline is there to save money. So it's really important to get it out that we're making these recommendations in order to improve care, standardise care, and because the evidence says this is the best way of doing things. A major drawback for NICE has been that it's become almost synonymous in some eyes with a rationing organisation. Now, it isn't a rationing organisation. I think it's a terrific organisation. I think it's getting much better at explaining why, but it's kind of been forced into that. So explain how the conclusions were reached. Explain what you were trying to achieve. We were trying to work out what is the absolute best level of care that we can achieve for our patients in this area, and this is how we went about it. This is the way that we reached these conclusions. Something that I think confuses people is the difference between population benefit and individual benefits. So people expect if they're being given a drug, that it will always work for them. And if it doesn't work for them, that the drug doesn't work, rather than it just doesn't work for them. And actually some doctors think that as well, I've found. So I remember hearing a doctor say, well, you know, the guideline says that this drug works, but this patient is telling me it doesn't. It doesn't work for them. The guideline won't have said it will work for absolutely everybody. So I think we need to be honest with clinicians and also with patients that for 80% of people, perhaps, this is likely to give you a good outcome. It doesn't work for everybody. If it doesn't work for you, then we'll come back and we'll have another think and we'll look at the next level on. But also when we're making these big decisions for population level benefit, and I'm thinking a bit about the statins debate, as in how many people at what level of risk should be prescribed statins. Let's accept and let's be honest about the fact that yes, statins do save lives, but they don't save everybody's life. And let's be clear when we're talking about this in the media that at a population level, it may save X number of lives, and let's not get into the figures of that. But on an individual level, there will be people who will be taking them unnecessarily, and that's just how it works, and I think we have to be honest about that. If the decisions are being made for resource constraints, because of resource constraints, personally, I would say let's be honest about that. people do understand that there is a limited amount of money. They don't like it, but then if we tell them this is what we can do for the resources, for the patients or to the general public to go and say, we need more money for this, because our doctors are telling us this is the best they can do within the resources that we've got. We need more resources. So it's not entirely down to you to say, this isn't a resource-driven issue. If it's a resource-driven issue, let's be honest about it. And then the pressure is back on the people who provide the resources. Final thing is about explaining risk. You'll hate as much as I do the headlines that you see in the national press where it will say, such and such halves the chances of this or doubles the chances of that. And nowhere in the story does it say what the original risk of this dreadful or appalling thing happening is. So I always struggle a bit with Cochrane reviews for that, because very often everything will be explained in terms of relative risk, and it's quite hard to work out what the absolute risk was that you're working from. So that's just a bit of a plea, particularly if you're going to do press releases, get across to the general public. We really do need to know the absolute risk as well as the relative risk if we're going to be able to do a good job of communicating to. So that's pretty much all I wanted to say. So really just to sum up, I think that we have more to lose by not doing a good job of explaining guidelines than by really focusing on how to do this best. And what people need to know is who's affected, and then you need to think about how to reach them, what it is that's changing, how people are going to be affected, and as personalised information as possible. Think about when to involve and when to communicate with patients. And last and clearly not least, why those recommendations are being used. Thank you very much.
Okay, thanks very much, Anna. Well, just before we open up to questions and whatnot, I'd just like to ask Helen if she'd like to comment on things from the point of view of receiving all this information and advice.
Yes, actually I'm quite happy to go up there if that's all right,
fine.
and just give a 5-minute introduction. I'm just going to speak very briefly, explaining the context in which I have been asked to join this panel today. I haven't got a presentation, mainly because, I'm an active carer of someone affected by cancer at the moment, and I haven't had time in the very short time available to me. However, I speak first and foremost as a patient, and I think it's helpful for all of us to remember that many of us at any given time are actively patients of the NHS or our national healthcare system. I think that can inform our views, our judgment, and our work in a most effective and timely manner. I think many of us are also carers, and we are doing this in the context of our work of developing guidelines, seeking implementation and evidence of implementation, and also increasing the focus that patients and the public can bring to guideline development. So I'll say a little bit about the context of some work that I have done in relation to my own organisation. Voluntary Health Scotland is an umbrella body of patient organisations and voluntary sector groups, 300 organisations across Scotland. For 11 years I was involved in this organisation, and one of our main focuses was to respond to the government's initiative at the beginning of this century in 2001 to involve patients and public as participants in healthcare delivery and development in Scotland. We carried out this agenda, and as far as I know, because I've now left the organisation, the work is still continuing. One piece of work that we did was in cooperation with SIGN, and it contributed to the DECIDE piece of work. If you have time, there's a poster on display in the open area which is adjacent to a larger piece of work carried out by NICE, National Institute for Healthcare and Clinical Excellence. We carried out a small and fairly limited patient survey looking at the extent to which patients and the public were aware of SIGN guidelines, and even more importantly, whether they were aware that they were actually being implemented and applied in their own personal situation. I'm not going to go into any detailed account of that small piece of work, except to draw a few observations from it. One of the things is that we were very focused at Voluntary Health Scotland on contributing to righting health inequalities. And inequalities of information are a major element of inequalities in many countries. So what we wanted to do was make sure that as many people as possible could answer our small survey, could respond to it. And I think it's interesting to note that while we distribute it to potentially about 2,000 people, we were very, very keen to capture people in communities which were disadvantaged by reasons of isolation, poverty, etc. And we really only managed to field about 12% of useful responses to that inquiry, which really shows how many people were actually being excluded for all sorts of reasons. One of them, of course, being simply poor access to the internet, which does affect still, I think, some 15% of people in Scotland anyway. And those are likely to be people already suffering from disadvantage. What was very interesting was that for more our respondents, they were very aware of SIGN guidelines, and they understood, and I should say that SIGN Guidelines, Scottish Intercollegiate Guidelines Network here in Scotland, they were very aware of the guidelines, they understood them, and what was particularly appreciated were the patient versions of these, which Karen Graham here at SIGN has been assiduously developing since 2007. These were, at that point, a fairly limited number in range, but they were much appreciated and they were well understood, which rather echo the points that both Karen and Anna have been making. The other interesting thing was that our respondents were nearly always older white women and of a certain educational level. So I feel very strongly that we have to redouble our efforts to redress the inequalities of access to information in guideline development, dissemination, and indeed in healthcare generally. What was quite interesting was the means by which people became aware of guidelines, and this is actually 2011 that we did the work, so things have moved on a lot since then. But at that point, people were accessing guidelines on the website, and those who are familiar with the SIGN website will know that it receives millions of hits per month, so the access to the web-based guidelines was very good. Interestingly, and this reflects an earlier piece of work that we did, that many people liked to have a paper copy of a patient version of the guidelines, and indeed they liked to be given that by a healthcare professional. All the evidence that we accrued over the years showed that for many people, the verbal word to accompany the printed word or the word was actually of great benefit. So if these can be handed out, that's helpful. Some of the other points we noticed was that we were very keen not just to focus on, if you like, patient awareness, but very much on patient participation. And we looked at ways in which patients could participate in the development and dissemination of guidelines. And again, I have to blow SIGN's trumpet for it, but they have been particularly successful in involving patients in a number of ways, crucially in guideline development, but also, of course, in review meetings, in public meetings where guidelines are being launched, and very importantly, as SIGN volunteers. And this is a small team of people who will go to conferences, events, training courses for junior health personnel, and actually verbally explain the context and the value of SIGN guidelines and healthcare guidelines in general. So participation, I think, is very important, and that begins right at the beginning. It begins right at the point where you're selecting a guideline topic, right through the process of development and through into implementation. One of the things we were very interested to find out from the public was whether they believed that guidelines made a difference. So I kind of split that into two bits because I was interested in what I might call application. In other words, where the guidelines being applied in that person's individual care. And this again mirrors what Anna's been saying about, individual perceptions and whether guidelines are useful. Those few people who were aware that guidelines were being applied in their own case were very positive indeed and felt they were of great value. But we also wanted to know whether they appreciated the extent to which guidelines were being implemented in Scotland. Now, clearly they had no technical access to that information, but they were sceptical up to a point. They felt that the evidence-based guidelines were a huge resource, but they wanted to see evidence not only of them being implemented globally, but also evidence that that implementation was making a difference, both on an individual basis and on a population basis. So there are stages further that patients are interested in. You know, is this actually making a difference to healthcare in Scotland? So that's just a very small taster of it, and there are some summaries of the piece of work and the issues raised round in the poster area. The other area which I think is important, and there'll be a number of people here who are involved in the GIN, Guidelines International Network. And I came in the other day to find a small table had been put aside for me, cryptically labelled gin, but there were no bottles and no glasses. However, for those of you who are familiar with the work of Guidelines International Network, you will know that there is a significant group within that called GIN Public. And I and perhaps one or two other people here are members of the steering group of that. Over the last couple of years, we have been working on the production of the GIN Public Toolkit. I'm aware that this is by no means the only toolkit focused on involving patients and the public, but it is a very useful one, and it is evidence-based. I know that some people are already using it, and you can access it on the web. I have one or two display copies which people might like to look at. Some people here have contributed, focusing on all the elements of involving and seeking the best participation of patients in guideline development. And indeed, there are many flyers of this that you can take away. That is about all I have to say by way of background, but I will perhaps draw on some more of these points as the discussion ensues. Thank you very much.
Okay, thanks very much, Helen. Just on the last point about the GIN toolkit, could maybe mention that part of the work of Working Party 3 have decided is on updating parts of that toolkit, and Karen Graham is running a workshop on that. I think it's later today, Karen, is that right? Yeah. Okay, well, now it's your turn to contribute to the discussions. So could I invite anybody who wants to ask a question or make a comment on any or all of these presentations. If I could just remind people to come to one of the microphones and press the button to speak. You're interested? Anybody?
Good morning. I don't really have a question yet, but I only want to introduce myself. I'm a patient representative of Tick Bite Disease Foundation in the Netherlands. Karen Graham invited me. I don't know if Karen Graham is in the... Okay. So we'll meet today. Okay.
There you go.
My name is Graham Bell, and I'm a patient. Sadly, I suffer from what Bruce Guthrie was talking about yesterday. That's multimorbidity, so I've got lots of things the matter with me. And they started about 20 years ago. But I've learned over the years exactly what to do to get the information I want. I've been involved in SIGN guidelines and involved in NICE as well. But I'm perhaps unusual in knowing where to go for the information that I want. But what do I do automatically when I get something new? I go to a page on my computer which has got Google written on the top of it, and I write one word or two words or perhaps even three words in the little box and press submit. Now, it's very easy to be critical of Google, but I suspect it's what, in the real world, most people who are fortunate enough to have access to a computer, it's what they do, it's what they use. That is one of the ways in which we get information, and it should never be forgotten, although we should be critical of it and careful about how we use it. So this is really just a comment rather than a question. But it is important that the information there is good and that it is directing people to the right place, and that there are very good websites which will do that for you.
Well, Karen, you want to comment first, and then Anna?
I think that's right, that we're not going to change the fact that people will go to Google first. I've got some questions, because I'm not very IT literate, that are there ways in which we can improve the way in which evidence-based guidelines appear on the Google list? You know, we all know you have to appear within the first 10, preferably within the first 3, and there are things make sure that keywords, links, and etc. put you higher up that list. But also I think that there is a need for training of patients around what is good evidence. So when they are doing web searching, and there has been work done in Australia on this field, and it's something that we just assume that everybody is just Googling, but I think we can train patients in that way.
A quick plug for something that can help with this in the UK certainly is the Information Standard Organisation, which was set up about 5 years ago. BMJ's been involved with it since the beginning. It was set up by the Department of Health, although it runs independently from it, and it requires, or to become a member of the Information Standard, you have to have a fairly rigorous way of producing patient information. So if you do have an Information Standard membership and there's an IS logo on the information that you've found, then you know that it's been produced in a fairly rigorous way and that it has been tested and spot checked. Now, most of the organisations that have joined the Information Standard are charities, a lot of third sector, a lot of charities, some NHS trusts, very few commercial organisations. I think BMJ is one of the few that is actually a member. What we don't have is much in the way of guideline developers, of professional bodies, of royal colleges. One thing that struck me, one of the royal colleges wanted to join recently, which was great, and I won't tell you which one it is for reasons that will become obvious. The BMJ is one of the spot checkers of information for people who actually try to become members of the standard. So they go through the process. A couple of pieces of information are put forward to be checked as a sort of spot check which is done by BMJ and a couple of other organisations. So we got this submission from one of the Royal Colleges. Great, very happy to have it. They'd submitted a clinical guideline, and we said, but this isn't patient information. Oh, it will be very interesting to patients. So we looked at it, and it is entirely addressed to clinicians. And, okay, we'll assess it, but you will probably fail on patient language. Are you addressing the audience? Have you thought about the audience's needs? And it just seemed to me very sad that an organisation that clearly wanted to be involved in something like the Information Standard really hadn't got it in terms of thinking, well, what is appropriate, what is useful for patient information? Sorry, I've gone a bit off-piste there, but I hope that's useful anyway.
Just a small point about evidence. Sorry, I'll stop in a minute. Is that I think this is a really challenging area because, as we know, guidelines are based on defined population research and are applicable to populations. Patients, I think, are still very interested in evidence, meaning what works for me. And I remember one very sort of critical situation when the SIGN guideline on the non-pharmacological management of depression came out, which evoked a very strong response from one of the mental health charities. The evidence suggested that there were only really two main therapies that actually made a difference, one of these, of course, being CBT. And this particular charity became very exercised, and I felt very rightly so, on behalf of their many members who said that actually there were many other therapies, particularly talking therapies, that were very powerful and that worked for them. So I think there's quite a challenging area around the whole business of managing and presenting and implementing evidence in patient terms.
I think that is a real problem, because I know that in our guideline groups, in some cases when you have patient representatives, they do come along with evidence that's convinced them what's good for them. But if you look at it in terms of the quality of evidence that we normally use, it doesn't really hold up, and that can cause quite a bit of a conflict, I think.
I'm Stella McPherson. I'm a patient representative. Where people can choose to use the guidelines or not choose to use the guidelines. That's question number one. The second one is with health boards being able to decide what their local priorities are, that this in a way still leaves postcode lotteries, because what one person gets from one health board isn't necessarily going to get it from another health board.
I think it's actually helpful in this debate to differentiate between medicine, an individual therapeutic use of something, and what you're doing in guideline development, because I think guidelines are different and gives you different challenges. So a clinical guideline will tell you the highest quality evidence that moves from diagnosis through to early treatment, through to later treatment, through to rehabilitation. So it gives you evidence really about the whole pathway. And in most countries, even in England, there is no mandate about implementing a guideline, unlike there may be with an individual medicines assessment. And the role with patients is different. I think that what the guideline is telling you is what the highest quality of care can be for a patient on their patient journey. And so therefore that's how I've seen patients, and particularly patient groups, using it to say, actually, aren't getting diagnosed in this way, they're not getting access to diagnostic tests, etc., then they're then not being given these options for therapy. They're not being given these, particularly rehabilitation is often a big issue. So it's a kind of different question almost, because it is about the whole pathway of care. So I think it should be essential for any patient who is working within a health system to improve the quality of care. In Scotland we have managed care networks and patients involved in there. So it's about the whole pathway of care and improving that. To a kind of postcode lottery, because it's about the whole care pathway. Helen Mike.
I'm Larry Melnicker. Thank you for a great session. I'm from New York. I had the privilege of going to the National Academy of Science in Washington last fall for a fascinating meeting on the science of scientific communication, and it was ostensibly about how to speak to the lay public about science. And one of the main take-home messages was storytelling. One of the foundations of healthcare inequality is the unevenness of health literacy. And some patients don't understand the evidence or how we generally, as methodologists, will present it. So the question is, how can we tell stories about the guidelines that we develop?
That's an excellent point. And I mean, I'm very much aware of the need to, not so much, storytelling is a good way of putting it. It's about providing the narrative, explaining, okay, so this happens for this reason, and then that leads on to this. It's about contextualizing it, explaining the background, making it relevant to people by talking about where it fits into their lives. I don't think it's an easy thing to do at all, but I think storytelling is a great way of looking at how we can do that, how we can explain in the context of a narrative that makes sense to the individuals. It's challenging, but it's a great way of looking at it.
Just one reflection on that. Within Scotland, we have something called the National Patient Safety Programme, and as part of that, it's person-centred, and some health boards now start their board meetings with patient stories, and they are not only important to patients, but they are important to decision makers. So patient stories in this context are often, for example, I've seen one around the implementation of an anticipatory care pathway. So when patients in disadvantaged communities are being given access to a range of health advice, and it is hugely powerful if an individual patient can indicate the way a healthcare intervention has made a difference to their own lives. And often that is about a journey of care. It's not about one individual intervention. And, you know, I'm sure that, you know, as I talked about ambassadors, and I do wonder whether there is a role for us to kind of work with patient ambassadors, and I'm looking at Helen here.
Well, yes, indeed, that's already happening, I think, that patient organisations frequently act as powerful advocates for change. And we know this already in Scotland in relation to the Scottish Parliament, where so often patient interest groups and individual patients will give evidence to the Health Committee on a particular proposed healthcare intervention or a new medicine, and the difference that that will make to them and the people they know and those affected whom they know well. It is a powerful tool indeed.
Hi, I'm Robert Flowerdew. I'm a GP just 50 miles from here, in a deprived area of Scotland, sort of in the sort of mining villages. And it was the point that Helen made about that even within the patient groups that we have already established, the deprived and vulnerable groups of patients are really not represented in these. And we also have to think about where their information, for example, we've had, if only it came from the BMJ, or even the Herald would be a step up. But it's inclined to come from the Daily Record. For of those of you who come from overseas, the Daily Record is Scotland's kind of cartoon mag, and is produced in Glasgow, and that's what most people get their health information from. And there was this, my daughter went to Canada for her elective, and she came back and she said, "Oh, Dad, you've got to see this." And it was a little video in a cartoon form called 23 and a half hours, and it was done by a Canadian doctor, physician. And it was about how half an hour, you could spend 23 and a half hours of your day sitting down in front of the telly, eating your chips, eating your sweets and all the rest of it, and you could do this and that was fine. All you had to do was give up half an hour of your day to a bit of exercise. And it didn't have to be the gym or whatever, you could just be a walk. And this cartoon just brilliantly talked you through the benefits of this with some statistics. So for example, half an hour's walking a day for 1 year has a better outcome in terms of improvement from angina than stenting. You know, only slightly better, not statistically significantly better than stenting, but it's as good an outcome. And you think, yeah, but, you know, stenting's an awful lot more expensive and an awful lot more dangerous. And it just goes through. It's a brilliant, brilliant cartoon. And I decided, right, I'm going to have this in my waiting room for all my patients to see while they're sitting waiting for me, grumbling about the hour that they have to wait to see it. And I think, which they often do, and I mean, most GP surgeries are sort of full of like a 1990s copy of Reader's Digest, aren't they? Really, you know, and some, you know, some poster that's sort of so out of date it's unbelievable. It was to try. I also think that, you know, you made the point about the Liverpool Care Pathway, which is a really. I think we have a battle with the media. The media are not interested in good news stories. Even if we look at the horror of the Mid-Staffordshire disaster in the NHS in England, in actual fact, Don Berwick, who was the person commissioned by David Cameron to produce a report on it, came out positively saying that the UK has got a fantastic system of healthcare with its NHS. It works, it's efficient, it's cost efficient. And yet, none of that was published by them. And we have a huge problem in getting the good news stories out about what we do. I remember when warfarin was being compared with riboxaverine in the press. What was it? Warfarin was rat poison. And I thought for a minute, let's think about what warfarin is. Okay, warfarin is like, if you were to design a drug, it's almost the perfect drug, isn't it? You can take it for the rest of your life. All it does is make your blood less coagulable, and it's got almost no side effects. Okay, we've got a wee problem with it in the sense that it's not always reliable in how well or badly it coagulates you. But the point was the media painted this drug as rat poison. That's how they described it in the headline. Doctors choose to give rat poison rather than riboxaverine. Now, who's driving that? The problem is that at the moment, guidelines are being driven by drug companies who have a vested interest in seeing new products coming out onto the thing. And we're not driving the good things. Look at dementia. Alzheimer's Society, through funding through them, forced NICE to allow the drugs through for dementia. I don't want to go into debate about whether or not Aricept is good for dementia or not. But one thing for sure is that there are a large number of healthcare interventions that have been shown to improve outcome in dementia. Like dancing's good, it reduces falls. Like walking is good. Like reading is good. Like talking to people is good. All of these interventions, the way our hospitals are designed, like where the toilet sign is unreadable, even at my age I can't read it, and where it's the same colour as everyone, so of course you walk into the cupboard and have a piss. That's what people do. And that's what's happening all over our country with our hospitals struggling, where you can't, and where the bedside tables and the lights are on all night and nobody can sleep. Of course they're awake all night screaming. All of these things have an evidence base, and yet none of them get pushed through. And we need to find a way to get the media to respond to things that are not financially driven, backed by huge commercial interest. Because medicine's not always about those things. Sometimes it's about the little things. And I beg all of you to watch 23.5 hours, because a half an hour's walk a day, no matter who you are, no matter how heavy you are, no matter how much you smoke, no matter how much you drink, will give you a better life.
I think that's probably a good one just to do some closing comments on. First of all, picking up on cartoons, let's congratulate Sign 100. Sign 100 is the handbook for patient and carers, which had fabulous cartoons in it. And I think we should be using cartoons and methods of communication for all of our patient population. I think that's absolutely key. And actually, we need to tell them to tell us how we should be communicating. We need to be engaging with them to understand how to best disseminate our information. And the other thing I would say is women's magazines. Sorry to the men in the in the room, but if you pick up a woman's magazine, there's normally about 10 pages about health issues. Where they're getting that evidence from, I'm not quite sure, but I doubt whether it's evidence-based guidelines. And actually, we should be feeding into these areas that people are reading, so the Daily Record, etc. And so we need to be engaging with them and speaking to people in their own language.
In a former life, I was a health editor on a women's magazine. The press releases arrived in their stacks like this, with free samples and all the rest of it from everyone who wants to sell you vitamins, yogurt things, basically anything that they can sell. I don't remember ever having a press release telling me that there was a new guideline out explaining that walking for half an hour a day would transform your life. And yeah, absolutely. Don't forget about that type of press. And make sure you've got a story to tell them, back to stories. That's the really powerful things. Particularly if you can involve patients in this, and if you can say, we have a group of patients whose dementia care is fantastic because they've introduced ballroom dancing. I'd write a story on that. That sounds fantastic.
I would just finish by saying, listen to the voices that are often muffled and not heard. Accompany that by their stories, and I think that will have a huge impact on both the media and on clinicians.
Okay, well, thanks very much, everybody, for your contributions. I was struck when Helen was talking, saying most of the people responding to her survey were middle-class women. And you'll have noticed that this panel is all female. So I think maybe one of the takeaway messages from this morning is that men should start reading women's magazines. Other than that, I would just like to say thank you very much to all three of our speakers for their contributions this morning, and also yourself. Thank you. That was really great. Thanks very much. Yes, went a lot better than I thought it might. Yes.
Good afternoon, colleagues, and welcome to this plenary session. My name is Patrick Bossut. I'm from the University of Amsterdam, and I have the privilege of chairing this session. And for me, it's a session that I very much look forward to, because we have three excellent speakers who are not only involved in developing recommendations and guidelines, but also know how these recommendations, these evidence-based recommendations, land in practice. And each one of the speakers will present a slightly different perspective on that aspect of our activities. It's my pleasure then to introduce the first speaker in this session, and it's Dr. Trudy van der Weijden. She holds the chair on implementation of clinical practice guidelines at the University of Maastricht in the Department of Family Medicine. And Trudy is interesting for this audience because she bridges two worlds. She's active in developing clinical practice guidelines. She's a member of the Guidelines International Network, GIN, in which she is co-chairing the GIN Public Group on Patient and Public Involvement in Guidelines. But Trudy is also active in shared decision-making, a topic that has come up in several presentations already. She held the chair of the International Conference on Shared Decision-Making in Maastricht in 2011, a few years ago, and she's also a member of the steering group of International Patient Decision Age Standards Collaboration. Trudy, the floor is yours.
Thanks, Patrick. Thank you so much, and thank you for the DCIDE committee for inviting me over. It's a real pleasure to be here, and it's so much learning here for me, and being with these great people in this great venue with great food and beautiful Edinburgh. So thank you, Sean, and the DCIDE community. And indeed, sometimes I have the feeling that I'm living at two planets. I mean, shared decision-making and clinical practice guidelines, they're too much separated. And my dream is that we are going to use each other much more and learn much more from each other. Another experience in my work is that I try to implement shared decision-making. And it has been shown before, this metaphor of this dance, this tango dance, for shared decision-making. Well, that's quite a challenge. I couldn't do this tango dance. It's not the easiest dance. And really, in shared decision-making, we have the challenge to make it simple and to really make it implement. And often the ambition level is too high of people trying to work on shared decision-making. I would be so happy already if doctors just have a small, easy, line dance or wooden shoe dance and move with patients in a simple dialogue. That would already make me very happy. And my feeling is, and being here and listening to all these great talks of these brilliant people, and I talked with Richard Lehman yesterday, that's also the sense that I have here, and there's also a challenge here for DCIDE and for GRADE. It's as if these people are so intelligent and they are so bright, and I think they underestimate the general brightness of doctors and patients. it's as if they are making, if we take the metaphor of painting and art, it's top of the bill. It's the Nachtwacht, which is, it's very detailed work, and it's highly skilled, technically skilled work. It's not easy to understand all the symbolism behind the Nachtwacht, and many doctors in general and patients in general, they are happy with an impression of the facts and the figures, you know. So we have a gap, and we have to meet each other in between, I think, in the middle somewhere. It's as if we, with these side projects, you are playing Wagner operas, while doctors and patients, they listen and they are used to Mumford & Sons or the Beatles. And I'm not sure if we have to educate doctors and patients, as was said earlier, totally to be able to listen to Wagner and to understand the most difficult art. I think we have to meet in the middle. So I think we share this challenge of implementation of our deliverables in real practice. So I will take you through some drivers for shared decision making and give you an idea of what is it, how do we define it, and what's the role of patient decision aids. And the main part of the presentation is, of course, on the guidelines and how can we merge shared decision making and guidelines. And we talk about collective patient preferences. Would be so beautiful if we integrate evidence on collective patient preferences into guidelines. But the most ambitious goal is to facilitate the discussion on the preference of an individual patient once we are in the consultation room. And it said earlier, but we have evidence on preferences of populations and big subgroups within the population. But this person in front of us as a clinician might deviate completely from, you know, the average preferences of the population. So what are the drivers? I just named some. There are many drivers actually for shared decision making. But if you look at this, the question is what you would do for your patient. There are some surgical scenarios given here. Your patient is diagnosed with colon carcinoma. This is a hypothetical scenario, but I can tell you this is quite realistic. The surgeon can apply two options. As you see, the cure without complications is completely comparable. But down in the bottom, we see that option one has some better survival, but the trade-off is nasty side effects. And these side effects are really decreasing quality of life and maybe long-term. So what would you decide for your patient, option one or option two? And please take another second. What would you do if you were diagnosed with colon carcinoma? This is what Peter Jubel did with hundreds of doctors in the United States, and I think it's representative globally. And it shows that we as doctors, we tend to choose for our patients more for aggressive treatments because we think they want to survive as long as possible. And we are not that much taking into account the burden of treatment, the side effects. While we choose for ourselves, we more often choose option two. Okay, then I die. Perhaps the odds for dying is a bit higher, but I'm avoiding these nasty side effects. So we have this helper syndrome. And it's logical that we have it, but we have it, and we are not realizing what our patients want. We misdiagnose preferences of our patients. Al Murley has written a beautiful report, and this is a summary in the BMJ on the misdiagnosis of preferences by doctors. A classical example is the early stage breast cancer. The women diagnosed with this disorder, they also face two options. The breast can be removed. There can be breast conserving surgery done, but then the patient also faces a high frequent radiotherapy. And mind you, this has really a high risk on long-term side effects. Think about lung fibrosis, think about myocardial problems. But the survival, really, in long term, there are strong data with 12 or even 16 years follow-up. The prognosis is exactly the same. Quality of life seems the same. There's a bit more uncertainty there. If you ask providers, clinicians, so what do you think is in the top three of your patients considering this dilemma? Then as you see, well, survival, of course, is top of the bill. That's number one. And keeping the breast is very important for my patients. And if you ask this to patients, then we have quite a big discrepancy here if we look at the top 3 concerns in breast cancer decision making. No, patients do in general not bother that much about keeping the breast. They bother about many things. And it's really a bit unfair perhaps, but the Dutch guideline on breast cancer says the treatment of first choice is breast conserving therapy, including radiotherapy. And I think it should be both. It should be both in the guideline. Patients do want to be involved in such dilemmas and decision making. This is from your country, Angela Coulter. She has made this famous report, No Decision About Me Without Me. And it shows that once you inform your patients about dilemmas and about treatment burdens and about the side effects of treatments, they are wanting to be active in decision making. What is this shared decision making? Kathy Charles has written a landmark paper. And she first defines the paternalism communication model. That's when we as a doctor, we give information about the option of our preferred choice to our patient, ask for informed consent, and make this decision. On the other end of the spectrum, we have the informed patient model, and we give the information of both options, the preferred option perhaps, and the alternative option, with all the pros and cons, and we tell the patient, have a look and tell me what you decide, what you want. I feel, and I believe, that only a very small minority of our patients are up for this model. That's the high educated group of people who are fit to make decisions for themselves. Most of the patients, and there's evidence for that, they feel abandoned with the informed patient model. Somewhere in between we have a shared decision-making model. And we are not then, as professionals, sharing our norms and values, which is in our guidelines, with the patients on the preferred option and the alternative option and the pros and cons, etc. But we are asking for the patient's norms and values. And the values about how do you value your quality of life, and how do you value these options and these side effects. And the patient and the clinician, they deliberate, and the clinician takes the decision, he or she is end responsible. But the clinician is involving as much as possible the perspective of this patient in the decision. This is, of course, a simplified model of reality. This is not reality. In reality, we have more complexity. We have all these pluses. We have many colleagues around the clinician. We have a team. We have many persons often around a patient with his or her culture, etc. And often it's not a static process. No, it's a very iterative process. It's distributed over many consultations sometimes. So it's very complex before we finally take a decision together. Glyn Elwyn and others have given a model for clinical practice that shapes this deliberation process. At least we need choice talk and option talk. And the choice talk is actually quite simple. It's an opening for this dance. It's an opening like saying, okay, you have this diagnosis. Now, we have one option, but there is another option. And there is the wait and see option. And there are pros and cons per option. And I know that patients differ in their preferences per option. Would you like me to tell more about the options? And then option talk will start. And option talk is what we have sensed here a lot. It's about the figures, and it's about the probabilities and the outcomes, etc. Patients may need support with patient decision aids. I'll come back to that. And then once all the options and the pros and cons are digested, and the values, each other's values are exchanged, then the doctor can say, okay, are you ready now for the decision, or should we defer the decision? Do you need more time, or do you need other people to consult? So we really want to help a patient who may have an initial preference or may not have an initial preference to construct an informed preference. And we know that preferences are not just static and in our mind. No, they are. These preferences are to be constructed together. Patient decision aids. give information, of course, on these options and the relevant outcomes for a specific decision, relevant outcomes for both the doctor and especially for patients, of course. And within the International Patient Decision Aid Standards Group, we've published criteria on what we think high-quality decision aids look like. And you can imagine there's information on the disease, of course, on this choice, this dilemma. And then there is far more detailed information on the options, the outcome probabilities per option. And as said before, it should be framed neutrally with natural frequencies, with population diagrams to visualize data for patients. It should include the wait and see option. And last but not least, a patient decision aid should include something that helps the patient to elicit his or her values. I will give you an example. And it should give the patient information on the process of decision making. Dawn Stacey, she has reviewed over 100 RCTs where patients were exposed to patient decision aids, either with or without shared decision making in the clinical encounter, compared to patients in usual care. And there's level 1 evidence now that knowledge of patients really increases dramatically. Patients are more involved in the decisions taken are more in line with their preference. Patient adherence does not increase, but there is a 20% reduction in invasive treatments once you expose patients to patient decision aids. 20% in elective surgery, that is. It's a big difference, I think. Health is the same, and anxiety is also the same. Patients do not get anxious by being exposed to this information. Here's an example for patients with breast cancer. This is from Cardiff. It's called BreastX, and this is what patients can use as a patient decision aid at home. It's web-based, it's interactive. There's a lot of spoken language if you want. There's a lot of videos with narratives in the BreastX patient decision aid. It's quite complex, but you can be supported by nurses, breast cancer nurses, to go through this, or you can do it at home by yourself. And the options are given, and then here you see this value elicitation tool. It's like filling in a questionnaire, and then you get the scale to, you opt for either one or the other option by how you fill in the questionnaires on your the questions on your values. There's a new move now in developing patient decision aids. This is also from Cardiff, the option grid. This is a very brief, small patient decision aid. It doesn't comply to all the IBDAS criteria. It's only 1 page, and it's additional to this extensive patient decision aid. This is just 1 sheet, and you can use it during the clinical encounter, and the doctor and the patient go through it together. And have a look at the left column. Here you see that this is far more patient-driven, such a option grid. Here are the frequently asked questions, mainly by patients. And not only about survival, but if you look at the bottom, also on practical consequences. Will I lose my hair? That's what's important for patients. So what can we do in guidelines to facilitate shared decision-making? As already was mentioned by Helen Tyrrell, we have in the GIN, we have a working group on patient and public involvement in guidelines. And there's a lot of tools there. I'm not going into the details. There is a flyer still on the GIN table. But there are 3 means to have patients participate in guidelines. We can consult patients. We often do. That may be focus groups at the beginning of the guideline procedure, to find their important problems, the issues, the relevant outcomes. But there is so much more often. There is often already a beautiful literature on, for example, qualitative work on treatment burden, or quantitative work like discrete choice experiments on patient preferences. We should use it. We think that the treatment burden should get more and more attention, and there's a lot of research going on now on treatment burden, how to define it, how to measure it. I think that's good. Perhaps the strongest way of having patients participate is in the guideline committee. And they are in the highest level of power then. We know from Gin Public that you cannot just easily do it. It takes a lot of coaching and attention and time for patients to guide them in this process. But then they can really give us the relevant issues and problems and outcomes also for our PICOs. So we have to involve them already in the scoping phase. I will give you some strategies now for how to communicate guidelines to patients. Once the guideline is ready, there's still a lot to gain in communicating it to, of course, the doctors and the patients. So think, for example, the patient version of a guideline. But the real challenge, I think, is to make the guideline in such a way that it facilitates shared decision-making on an individual level. If this symbolizes the guideline, it's a big, often a PDF with many recommendations, and the blue one is a strong recommendation, and the orange one is a conditional recommendation. So I think we need to, for the implementation's sake, add tools to recommendations, but for strong recommendations, which, for example, is prescribe a low-dose aspirin to a patient who has suffered from cardiovascular disease. We know that this is effective. It prevents a second event. It has a low treatment burden. Patients are willing to take these drugs. It's only once a day, and there is no big impact on resources. So we have to give a clear recommendation, explain the rationale, be more persuasive than in the language in our recommendation, and add implementation strategies. While for conditional recommendations, think about breast cancer, we need different tools to support deliberation. Make options explicit, not only one preferred option, but the both options. Give the probabilities and frame them neutrally. And give perhaps recommendations on the level of deliberation. There's things are going on in the Netherlands, in the Dutch College of GPs. Guidelines are made, and the Dutch government is intending to, on the patient portal of the Dutch College of GPs, to disclose their patient decision aids. It looks like this. And at the same time, the hospital specialists are working on developing option grids together with guidelines for these subjects. My worry is that it's going to be all over the place. And we were discussing this with Karen Facian this morning. How can patients find then the good material and the good information? Where are the patient decision aids? There should be one portal. My dream would be that, and it's not, we didn't accomplish that in the Netherlands yet. If we have a digital patient information file, and you as a patient, you own your patient file, we have it only in one hospital yet in the Netherlands, in Nijmegen. I think that would be for the future the patient portal to link all the guidelines and patient decision aids to your own patient file. That would be a dream. The Dutch Healthcare Institute is trying to add another tool to structure guidelines and to make a tool with a clinical path. It's like NHS does with the map of medicine, and you can then highlight the preference-sensitive decision in your guideline. You have now you arrange the recommendations in a linear order, and it indicates the timing of when to hand over a patient decision aid. So should we add tools? Perhaps should we reshape complete guidelines, or should we reshape perhaps specific recommendations? We don't know yet, but there are ideas, and it was mentioned yesterday by a local doctor. Let's use the same recommendations and evidence tables for decision support with the language and the format that's understandable and easy to use for patients and doctors. For both of them, let's not work with patient versions of guidelines and doctors' guidelines. Let's merge these into one product. Per van Vik did show a beautiful platform where guidelines and patient decision aids are already a little bit together. You can find it on the same platform. And yesterday, Thomas Agoritsas showed me the Share It project, and I'm so impressed. And here is an attempt, it looks beautiful, to integrate patient decision aids in the guideline document. And there is a pitfall by doing this in this shared decision making. Actually, there's a pitfall that we lose ourselves in communicating probabilities and risks to patients. Doctors may find that secure, but we have to talk about with patients not only about the facts and figures, but the practical consequences, and that's in the Share It tool. And they give an icon display, and patients can pick an icon. Dear doctor, I'm so interested in how to take the drug. I think that's a beautiful move. Last year in the Netherlands, a guideline has been launched by pediatricians, made by pediatricians. It's on pediatric palliative care. It provides recommendations, it's very special, in a separate chapter on how to engage the patients and the children in the difficult decision-making on end-of-life decisions. How to do the shared decision-making, it's special. So we were asked to observe this, and we interviewed the pediatricians who used it. It was really a disappointment for the guideline developers. What we got back was, okay, this guideline, I was digesting it, and I didn't even digest all the clinical recommendations, let alone this separate chapter. I haven't even seen it. Then we asked these dedicated pediatricians, okay, but would you be open for a different type of recommendation where we squeeze in patient preferences? It could look like this. This is a clinical recommendation from the guideline. And we could then change it into, okay, first choice recommendation for pain relief is this drug with dose A, but you can opt for an alternative option, lower dose B, as some children, they do not see that these effects of the high dose counterbalance their pain relief effects. They get too dizzy, etc. And here's evidence of heterogeneity in preferences of patients. Actually, nearly all the dedicated pediatricians were enthusiastic about this. So we have an opening, I think, here in changing recommendations. It hasn't to be very complex. This is the latest guideline on diabetes launched by the Dutch College of General Practitioners. You will recognize this guideline. We have to monitor every 3 months patients with diabetes for their glucose, the recommendation. But it could be like this, giving us an alternative option. Namely, for patients with diabetes without symptoms and well regulated not only on glucose but on everything else, and the lipids and the blood pressure, we can together choose for a lower monitoring frequency. And I think that's an opening for shared decision making. That's a beautiful way of phrasing a guideline recommendation. Some guideline recommendations are already recommending on the way that we should deliberate with patients, like Stephen Wolf showed. It's about mama cancer screening. The decision to start biennial screening mammography before the age of 50 should be an individual one and take into account the patient's values regarding specific benefits and harms. Okay, but how exactly should I do this? So we have to rephrase this, I think, or that's what Stephen Wolf showed, like this. No routine screening for these younger women, that's clear. For women in this age group who still opt for screening, prescribe the patient decision aid, refer to the mama care nurse for coaching, and take a decision in a follow-up visit. I think that's far more clear. That's how we should go forward, I think. So to summarize, we can, in trying to facilitate shared decision-making through guidelines, we can offer generic strategies to doctors and to patients. And these may be a separate chapter on shared decision-making or language that involves patients throughout the guideline. And for patients, of course, a patient version of the guideline. And my dream is that this will be the product for both users. I think we can find more strength in strategies related to specific recommendations. And I gave you a few examples, like restructuring the recommendations and giving alternative options, or structuring and recommending even how to deliberate with patients. And of course for patients, providing linking patient support tools to the guideline, or like Thomas does in Share It, put it in the guideline. So I hope that these different planets merge into this one beautiful planet that we have. And I realize that integrating shared decision-making may add complexity to guidelines, and we have to keep things simple. This conflicts with the urge for simplicity, as I gave you in the beginning. We cannot do tangos and Rembrandt and Wagner operas. We have to find this simplicity. But within that, I think we can reshape guidelines and recommendations, and I'm already happy if we start with a little bit of choice talk. Thank you for your attention.
Well, thank you, Trudy, for this overview of shared decision making. We have time for one or two questions. Maybe I can ask a question myself. Do you see any changes in the training of medical doctors nowadays? Because there's not much use of decision aids if there's little change in the training. And I know there's an increased emphasis on communication, but from your perspective, do you see any changes in the training of MDs these days in this direction?
Yes and no. In the Netherlands, we have been in a shift in training doctors in communication. I myself was a victim, and I've been extensively trained. Perhaps that's a good example. I've been trained so much in Maastricht University. We had the McMaster model and a lot of attention for communication. We were practicing with simulation patients and videotaping ourselves and discussing it in groups, not just for 2 hours in the curriculum, I think for 200 hours. Mm-hmm. And then we were tested on our communication skills, and we should have dialogues, and we were improving in our skills as medical students. But then you enter your internships, and I can tell you, if the role modeling is not what you have been taught, and we were punished for our behavior. So after our internships, our behavior and our skills were dramatically decreased. So it's not just a matter of more and more training young doctors, it's also keep them training and have better role models in the clinic. So it will take some time before we accomplish that.
Well, thanks so much for it. Yeah.
Thank you.
Okay. Well, thank you, Trudy. We now move to the second presentation in this session. And this is more or less inspired by Work Package 4. In Work Package 4 in this side, which focuses on recommendations for testing, we very early on agreed that screening was a good example in which you have evidence and also are dealing with multiple parties. Screening relates to policymakers, healthcare professionals, and also patients. And it's my pleasure actually to introduce the next speaker who will talk about screening. It's Dr. Harriet van Veldhuizen. She's the director of the Dutch Bowel Cancer Screening Program and affiliated with the National Institute of Health and Environment in the Netherlands. And she has been responsible for the Bowel Cancer Screening Program, which has introduced this year in the Netherlands after a positive recommendation by the Dutch Health Council. Harriet has a background in public health, and she drew up an action plan in collaboration with relevant stakeholders and coordinated all efforts in launching the program. And she will share her experiences in communicating the results and organizing the program as she has developed it. Harriet, I look forward.
Well, I'm very happy to be here today at this Decide Congress. I think you're doing very important work, developing guidelines, but also looking at the communication process. It's necessary to implement a good guideline, I think. Well, as Patrick told, I'm working on the Dutch National Screening Program, and we just launched it a few months ago. We had a very long path of preparation and decision-making in the Netherlands, and it really seemed a smooth process with a lot of evidence. But anyway, in the preparation process, we had some hiccups we had to come over. And now we have started the program. We also see that we have unexpected results in our program. So in a few weeks, we have to decide to enroll our program in a different way as we planned for the last 2 years. So I would like to show you what we did in our program the last 2 or at least 10 years, I think. Well, so let's start with the bowel cancer in the Netherlands. It's the third most common cancer, and we have about 6.5 cases of bowel cancer per 10,000 inhabitants. And as you see in this figure, there is also, even if we have a small country, the Netherlands, about 16.5 million people, there is a regional variation in incidence of bowel cancer. We had in 2012 about 13,000 people who were diagnosed with bowel cancer, and approximately 5,000 people died of bowel cancer. And as we know, about 90% of our cases occur in people aged 55 years or older. Bowel cancer has an intensive treatment and a considerable burden to the patient and high risk of complication at high cost. So this is a program that is interesting to look for if there is screening possible. The average 5-year survival rate of bowel cancer is about 60%, and it's very different in staging. Stage 1, we have a 5-year survival rate of 49%, and for stage 4, it's 8%. So if we are able to diagnose in an early moment the bowel cancer, we can heighten our survival rate. So it's very interesting to look for a good screening instrument for bowel cancer. And there was a landmark study in the National Polyp Study that showed that when we look at adenomas, it's possible to prevent bowel cancer. And we have a very long pre-malignant adenominal state before bowel cancer is developing. So if we are able to change the polyps and the adenomas, it's a good way to prevent bowel cancer. But also the early detection of bowel cancer is good. We can organize less burden to the patient and greatest chance of successful treatment if we are able to have a good instrument. So in 2005, we started a process of decision-making in the Netherlands to start a screening program. At that moment, we already knew from literature that there were good randomized clinical trials on GFOBT. It's a stool test that looks at heme in the blood, and it showed using this screening instrument that it's possible to diminish the incidence of bowel cancer. But it isn't a test it's a test that has a lot of burden and not a really attractive way for the patients. So in the Netherlands, we decided to look for other screening instruments to use in our bowel screening program. So in 2005, we started research on different screening methods, like the GFOBT, but also an immunological test, the IFOBT, but also colonoscopy and SIGMO and CT colonography. So we did a lot of research on all these different screening instruments, and in 2009 we had gathered all this research in a report of our Health Council, and they advised on the best screening methods to use in the Netherlands. And they looked at health gain, at cost effectiveness, at the balance between desirable and undesirable effects of the different tests. So we looked at different strategies, and all strategies use different screenings, but refer to a colonoscopy, and in the colonoscopy we can look for the adenomas and the bowel cancer. This slide shows this slide is a slide of our report of the Health Council, and it shows the relative merit of the different screening methods. As you see with attendance with the SIGMO, it has a negative sign, and we had a very low attendance rate in sigmoidoscopy. And I heard yesterday it's very different in the different countries, because in Norway they found about a 70% attendance rate with this screening instrument. So it's highly variable between different countries. But we also have problems in the Netherlands to introduce sigmo and colonoscopy, because we have little capacity in the Netherlands for colonoscopy. So it's not a very interesting screening instrument for us to use. But we also looked at the IFOBT, and we had a much more higher attendance rate in IFOBT than in the QIAC instrument. And the IFOBT is also a stool test, and it looks at hemoglobin in the blood. And it has a much more better test performance than the QIAC, because it has 2.5 times, detecting 2.5 times more bowel cancer and 2.5 times more adenomas. So at the end, our health council decided to advise to our minister to introduce a screening program with IFOBT. So that's what they advised, and they advised on age groups and cut-off level to use, and the screening interval, etc. And we modeled all data in a model, and it was advised to start a screening program with people from 55 to 75 years old in a screening interval of 2 years with a phased introduction. It was a phased introduction because we needed to build up our capacity in the Netherlands, because we don't have a lot of gastroenterologists doing all the extra colonoscopies that are needed. So we plan to invite this year about 850,000 people, but at the end, when the whole phased introduction is ended, we expect to invite about 2.2 million people a year, and we expect at the end to do about 70,000 colonoscopies extra a year. So that's a lot to organize in a small country. But the Health Council also looked at evidence, and they forecasted that the 5-year survival rate of after screening would go up from about 60% to 85%. And they also looked at health gain and expected that we would gain about 2,400 deaths prevented each year. So there was a lot of evidence introducing this program. They also looked at the yield after colonoscopy, and we expect about, in 1,000 participants in the screening program, we expect about 50 referrals for colonoscopy, and about 4 will have bowel cancer and 27 advanced polyps. So we have, in about half of colonoscopies, we expect yield for our program. And they also looked at the different advantages and disadvantages of the program, the early detection of polyps, the treatment that gives less burden, and the stool test that is free because it's an offer from the government. Those are some advantages of this program, but there are also disadvantages, like overtreatment, or that the screening test doesn't give 100% certainty, and that there are risks associated with colonoscopy. So they described both advantages and disadvantages, and they concluded the advantages are much better than the disadvantages. But they gave also other arguments, like the cost per life year gained, and we have a kind of a standard or limit to assess a new screening program, and it's about 20,000 euro to cost per life year gain to introduce a new program, and our program shows it's much better. But also they looked at complications, and that's a real risk of our program to have as less as much possible complication in colonoscopy. They looked at repeated screening, and all arguments were stated together in this report, and they finally advised the minister to start our program. And he said, well, there's enough evidence to start this program. I see we have a good quality of evidence. We see a good balance between desirable and undesirable effects, and the intervention looks wise use of resources. But I have some other problems. Is there enough capacity of colonoscopy? Is that sufficient? Aren't we creating long waiting lists in cure? Do we have good quality of our endoscopists, and do we have a uniform analysis in the IFOBT labs? And what about the GP that isn't referring a person with a positive IFOBT and hemorrhoids? And does the target group want to wait when we enroll our program phased? And last but not least, the finance of the program. Because of the early recognition, we need a lot of extra money to introduce this screening program. So he decided to start a feasibility study, and we spoke with all stakeholders in this feasibility study to see if there was a lot of commitment for this program, and we made an action plan for the preparation of the program, and we also looked how to finance this program and made a guess how much the program would cost. So that helped our minister to decide to start a program, and she arranged the finance that was necessary. And finally, she decided on June 2011 to start the preparations, and we finally launched a few months ago. It's important to know we have different funding systems in the Netherlands for screening and the follow-up in colonoscopy. The screening is financed by our Minister of Health, and the follow-up is financed by the Health Insurance Act. And every year, the government, the hospitals, and the health insurance companies make agreements on the annual budget. So that's what our minister had to arrange to introduce the program. She had to put extra financial budgets in these financial agreements. But because of these two systems, it's also for us it was incredibly important to make one unified system to align screening and care, and not to have a long waiting list when we are referring to care. So we decided to organize the program in a way all parties were involved. So we started a national committee where gastroenterologists, pathologists, health insurance, patient organizations, all parties were involved, and we agreed on that every agreement on this program and how it's organized was made by this national committee. So agreements on the selection and invitation process are made in this national committee, but also the message to the target group or the quality indicators of the endoscopist. And we had 5 screening organizations, 3 IFOBT labs, about 100 colonoscopy centers, and all general practitioners involved. So there are a lot of professionals involved to organize the program. And we started some working groups to make all the details of the agreements made in the national committees. And here you see a part of all working groups that started and worked on the program the last 2 years. We made agreements on national uniformity and quality assurance of the program. We also organized professionals who were working on quality assurance in the IFOBT, in the colonoscopy centers, and PA. And we organized a system to monitor and evaluate our program. And we already knew there was a difference between the different endoscopists in quality. So quality assurance was very important to organize, because we know we will get complications, and we know we are getting interval cancers. But then you have to be assured you have a good quality assurance system. And this slide shows that a study that before we started our preparations, that there is a correlation between cecum intubation rate and the adenoma detection rate, which is a very relevant indicator for our program. So we decided to organize an admission program for our colonoscopists, and they had to register 100 colonoscopies. They had to go through an e-learning, and they had to an examination on skills. And in this examination of skills, we learned a lot about the English program, and our gastroenterologists were trained by Roland Valori, who introduced the admission program in England. Finally, before we started, already 250 endoscopists were past the exam. Here's another slide that shows a good relation between quality indicators and endoscopy, and it shows the complications of colonoscopy and the number of colonoscopies performed by an endoscopist every year. And so we described all relevant indicators for authorization and auditing for colonoscopy centers and endoscopists in a protocol. And we not only described the indicators, but also the relevant literature, and which said it was a relevant quality indicator. So at the end, we ended up with about 100 colonoscopy centers that were authorized in our program. We had some challenge in capacity, and we expected in 2017 a shortage of colonoscopy of about 12,000 colonoscopies at that moment. We made some arrangements to overcome this problem, like reallocations, work to nurse endoscopists, or to change our guidelines on surveillance. And we built a national IT system, and I think it's very relevant we started to build this system, because we needed all the information together to evaluate our program. And the IT system is in the center of this slide, Colonis, and all parties involved, they send their data to this system, and they send it electronically to Colonis. Also, communication to the public is relevant. It is we have an informed choice system, and we really want to communicate reliable information on advantages but also disadvantages of the program. And we developed uniform communication products like letters and leaflets and animation and films and the website information, and also translated in different languages. We also organized information for the general public on websites and articles in newspapers and magazines. And because there are a lot of professionals involved, we also decided to have a continuous stream of communications to all these professional groups, and we organized regional meetings, and at the launch a documentation set, websites, and all different products to inform the professionals on their new task in the bowel cancer screening program. But we all organize these things, and you can plan these things to organize, but we also had unexpected discussions, and I think this is what really was challenging in organizing this program. The unexpected discussions we had in and where we had to deal with. And we had a discussion about the quality of our IFOBT test. Two gastroenterologists started discussion in the national newspapers of the quality of our IFOBT test that was tendered. They didn't discuss IFOBT as screening instrument, but they discussed the test we tendered and said this Italian test is not of good quality, and the National Institute only looked at price when tendering the test. So it was a very challenging discussion because also our Health Council wasn't convinced about the test we tendered. And finally, our minister decided to organize an expert meeting. And after this expert meeting, it was decided there was enough evidence to start our program, but also we are starting a research comparing the two tests. We also had unexpected attention in media, and this is one of our drawings in the national newspaper, Fokke en Sukke. It's in our daily newspaper drawing, and they looked at stool and they looked for a good stool to send in for a bowel cancer screening program. We had much more attention in media than we expected. We expected some newspapers to pick it up, but it was on TV, on newspaper, on radio, and we also had a lot of attention and promotion from hospitals on the bowel cancer screening program. We didn't expect them to do, but it was very good they did, and it was initialized because of the strong criteria we made on authorization of the colonoscopy centers. They were very relieved when they succeeded in the authorization, and they really wanted to let all the public know they were a center that was authorized. And now we have unexpected results in our program. We have a much higher attendance rate than we expected. We expected 60%, and I don't know why people attend more than we expected, but now we have an attendance rate of about 70%, and we have also a higher positivity rate than expected. And this gives us some difficulties because we saw the waiting times for colonoscopy rising, and we really need a lot of more colonoscopies than we expect this year. So we have a big problem to introduce this program the coming years. And we have a lot of discussion and with our minister at the moment how to deal with this unexpected situation. We have made advice for our minister to decide, and I hope she will decide in a few weeks. But it's not only dealing with this unexpected first result, but it's also important to frame a good message to the public at that moment. And it could be something like we have a successful program, the target group wants to participate, we have a good monitoring system, so we were able to organize short-term adaptation in the program, and we expect our minister to decide in a few weeks. In conclusion, it would be clear that starting such a national program without evidence isn't such a good idea. But I'm very convinced that it's not enough to start a program with only evidence. A successful implementation of a program needs more. It needs commitment of all parties involved. We really invested in strong collaboration, and especially in time of crisis like the discussion on the IFOBT test. I was very happy we had this national committee who was convinced we did the right thing at that moment. Expect the unexpected. There are always situations you can't prospect, and to deal with this situation and good process management and doing the right things at the right moment it's a tricky thing in such a program. Also, tight project management, managing deadlines is important, but don't forget the good collaboration with your commissioner, the ministry, and an investment in continuous communication and good framing of communication. For sure, there's more, but I think these are all important aspects in communicating a program that has a lot of evidence. Thank you.
Thank you, Harriet. Stay here, because there may be one or two questions. Yeah, Sean?
Hi, thank you for that. However, it just highlights just how difficult implementing health systems interventions are, given the uncertainties. I had a couple of questions. So the first question is, I know you've only been running for, I think it was just a few months, but do you have any indications as to whether the reach of the program is equally distributed across all parts of society, so the more socio-economically disadvantaged parts of society who take up the offer of a test less, because I'm pretty sure that's what happens in Scotland. That has been a challenge here. And then the second question, right at the end, your last summary point was about the framing of the communication to patients. I just wondered if you could say a little bit more about that.
Yes, the first question, we don't have results at the moment in our new program, but we had a lot of pilot researchers, and we saw attendance rate differing from 20 to 90% in Rotterdam in different neighborhoods. So we really have to deal with social economic inequalities, and that's the reason why we not only introduced letters and leaflets, but also introduced films and animations and such things, because we don't know exactly who to reach, but we wanted to have different communication methods to reach different groups. And your other question was about framing to the public, but I don't know what you want to know.
I was just wondering if you could say a little bit on how you present the information to patients. So I know a little bit about the leaflet that people in Scotland receive. It talks quite, and Amelia, I'm sure, will add more to this. So it presents not too much numerical information, but there is a lot of information available. So I was just checking the website now.
Yeah, we had a lot of discussion about how to present the information in the leaflet, and as you talk with professionals, they want more and more and more information in the leaflet, and we try to tighten the information to keep it simple, and we also decided to have a leaflet with the most important information, but to have extra information on our website because the higher educated people, they really want more information, but it's not working for a part of our group. We also want to inform on and give.
Well, Sean already mentioned Scotland, because from the Netherlands we now move back to Scotland with the next speaker, Dr. Amelia Crichton. She's a consultant in public health medicine based in Glasgow, Scotland, and she's the convener of the Faculty of Public Health here in Scotland, where she advocates for health policies like minimum pricing for alcohol and plain cigarettes packages, all aimed to improve the population health. Coordinates 11 population screening programs and is involved in the implementation of these programs. And they range from colorectal cancer to abdominal aortic aneurysm, diabetic retinopathy. I'm not going to name them, all 11 of them. And she will share with us today the Scottish experience of being closely involved in screening programs and more general evidence-based diagnostics.
Before we put the light down, how many of you, if you just leave the light up, how many of you have actually had a look at the YouTube video that Robert mentioned, the 23.5 hour? Up, move around a bit, because I think at 3 o'clock, having listened for an hour, you must be asleep by now. Okay, you can speak to your neighbor, turn around, everybody's standing up. There are some laggards there. Just move around, lift your arms, get the blood pumping. Yeah. So, Robert, thank you for reminding us all. And one of the key elements is actually, if you look at the burden of chronic disease, inactivity and lack of fitness accounts for most of our troubles. And my biggest challenge is actually getting people to exercise, to eat the right thing, to reduce their alcohol and so on. But I do screening by and large, and one of the things I'm trying to put in asked us to do to make them sexy and for people to take them up. So anyway, coming back to screening programs. So I'm a consultant in public health medicine. I've been here today, and I heard that there are some epidemiologists. So first of all, there are some differences in the way public health in Britain is run with the epidemiology. I do a lot of health policy. I do a lot of advising in terms of what goes beyond just healthcare. Administrative boundaries for how the healthcare is organized. In Scotland, for those who don't know, healthcare is free at the point of delivery. So even in Sweden, that I thought was one of the most democratic and wonderful places, you still have to pay if you go to any. In Scotland, everything is free for the patients. So our challenge, as someone mentioned, is actually ensuring that there are equalities in uptake, and whatever we do and make available is equally distributed, and particularly not as much equally as there will be a difference in the burden of disease and interventions uptake across the socioeconomic gradients. The population of Scotland is not equally spread. Most of it would be concentrated in Glasgow, where I work, so a quarter of the population is actually looked after by Greater Glasgow and Clyde Health Board, who's my employer. There are a lot of people in the Central Belt, but what you have is this huge area that actually is probably larger than the surface of Belgium and has about 300,000 people that live there. So it just shows the challenge we have in Scotland in delivering healthcare and ensuring that whatever we do takes account of the differences in socioeconomic outlook, geographical spread, and actually people's outlooks, because context, it's really, really relevant in what we do. So this is just some pictures. This is urban, affluent Glasgow, but also you'll see this is the middle of Glasgow, and also this is Glasgow. So how do we, when we put information out there, advising people on what is available, what they should do or shouldn't do, appeal to those who actually know everything about everything, nearly, and those who actually have very poor literacy or can't really read properly. And that is a real challenge we face. on a daily basis. So moving on, and how do we take decisions? This is just not, I don't expect you to read that, but the decision-making in Scotland, this is the Scottish government saying we work with everybody. Yes, so it's a very crowded scene. And since the devolution, we have the Scottish Government Health and Social Care Directorate, who has the responsibility for health. The healthcare has been devolved. It's fully within our power, and we do have to make it work for Scotland. So they're very interested. So I'm going to illustrate with the screening programs how we actually make research a reality. How do we actually translate it? Now, Harriet has actually given you the example of Holland, the implementation of the bowel screening. So I will not go through the detail of everything. So if you think of Harriet's, was it Van Gogh versus Turner, I'm going to give you the Turner, the Impressionist version, and I'm available for questions for detail if you want. Rembrandt, sorry, my apologies. The Dutch. So Scotland is part of the UK still. We're going to have the referendum in September. But this is Scotland. But we do have the 4 countries committee, the UK National Screening Committee, that actually sets up UK-wide policy. The committee actually considers the evidence that comes from primary and secondary research, and also commissions additional research. For instance, if we take the prostate cancer, a lot of patients groups are advocating, asking for us to put screening for prostate cancer, as it's one of the cancers that are on the increase. So the committee has actually commissioned a health technology appraisal to look at the evidence, whether we should do it or not. And they turned it down, as currently there isn't sufficient evidence. So the committee then makes recommendations on any topic that any country is going to ask to appraise, and they make recommendations to the ministers of the 4 countries. And then there's country-wide implementation. So to look at the range of screening that have been implemented, Patrick said he's not going to tell you all about them, but there are 3 cancer programs, cervical, breast, bowel, and then there are programs we offer during pregnancies. We offer screening to newborn, then we have diabetic retinopathy, aortic abdominal aneurysm screening, and preschool vision. So these are the national screening programs. What that means is that these programs have to comply with very tight criteria to be allowed to actually be considered as national programs, to spend a lot of resources in monitoring them. And I'm saying here implementation and monitoring. I'm going to take you through some things, because absolutely critical in the delivery of these programs is their monitoring. We cannot just put things into place. We need to ensure that we do deliver what has been expected. So I'm going to take you through some of them. I have bowel screening. Apologies for the flexible SIG, but that is flexible sigmoidoscopy. It's a new way of delivering bowel screening that we're going to implement, and I've been on my email account just because, like Harriet mentioned, there are always issues. So when you are supposed to implement something yesterday and I delivered it until tomorrow, I delayed it until tomorrow, I might have to delay it until next Monday, simply because that's the reality of being at the coalface and making things happen. Also, using different programs, I'll show you how, although we have a blueprint, each element or each program has some differences in terms of what evidence and how it works. Again, there will be differences. And when it comes to the implementation, it's the same blueprint, but there's always the reality getting in the way. So starting with the bowel screening, we use the guaiac-based fecal occult blood test. And this is our patient information leaflets and posters, just advertising that, yes, the screening is available. In terms of the evidence of effectiveness, back in 2001, I was still a registrar in public health, and the recommendation from National Screening Committee came to test the feasibility of implementing bowel screening in the UK. And this was the evidence that we were given. So a lot of clinicians, very enthusiastic, they thought there is enough sufficient evidence for us to actually go ahead and see, would it be really possible to make it happen? So we subsequently had the Cochrane, and the sign actually said that, yes, you have to continue. So in 2000, we started the UK-based pilots, and the aim was to test the feasibility of screening in real life in the NHS. No one believed that sufficient number of people are going to actually fill in the test itself. They all thought it's a taboo subject. The Brits, someone mentioned earlier, if it's from the belly button down, you don't go there. So there was real concern about the population engaging with it. So the committee recommended that we test it on 2 sites. One was the east coast of Scotland, and each site was about 1 million inside, and Coventry in England. So we ran the study, and after a year, we were terribly surprised that about half of the participants took part in the study overall. So all of a sudden was, what do we do next? Are we going to make it happen or no? It looks like the slides got stuck. Thank you. We gathered the data up to that point. There was a huge evaluation in place. There was qualitative research ongoing, looking at patients' attitudes, at their beliefs. There was quantitative analysis of the outcomes in terms of, do we realize the positivity rate, do we realize the capacity, and all these issues. And we had to make a recommendation to the ministers. The biggest stumbling block was the capacity of the colonoscopy, what followed. At that time, we had waiting times of about a year for colonoscopy. If you can imagine, I see one of the patients being completely shocked, but that was the reality of the service. So can you bring another additional program that will guarantee bring a lot of patients requiring further tests and make it happen? So we delayed the implementation, and we put in place developmental work in terms of training additional colonoscopies. We implemented nurse colonoscopy as a way of dealing with the service, built new facilities, and finally, from 2007, we had a plan to start implementing. And the 2007 were the boards that already had delivered a pilot, and then we had a phased approach, and Glasgow implemented in 2009. I won't bore you with the committee that actually is overseeing that, but certainly at that point, we thought, this is happening. And we were all extremely nervous because, what happens next? And today we heard about patients' views. And particularly when you're at the coalface, you really want to hear what's going on. And suddenly you're doing something right when you stopped in the pub by your friends and say, hey, I got the test, I didn't know you do this. There's a lot of positivity, which again surprises us, that people really, really do the test. There were patients that came forward and said, I turned 57 and I got this test, and that was the age my dad died. And they said that I decided to do the test, and something, it came positive, and I ended up with a colonoscopy, and they found the cancer. And I'm going to be alive because of that. So these are the stories that patients pass on to the other, and it kind of snowballs. All of a sudden, it's the patient's story that actually passes out beyond our efforts, because we do communicate, but how do you help inform consent? What are the things that truly matter for the patients, ultimately? We do have key performance indicators, and we monitor what happens across the patch. And there was a question about the uptake. Now, again, having IT in place is amazing, and having researchers to help us in addition to that is, again, extremely valuable. What I can tell you in Glasgow, the lowest uptake is among younger men living in the most deprived areas. They take about 40%. 40% of them do the test, while those in the most affluent areas, usually females living there, they are way over 60s, pushing towards 70%. Now, there are things we can do. And the Scottish government has spent a lot of money on Detect Cancer Early campaign. Now, there were a lot of people skeptical about things, but what we have found part of that campaign is the attitude that people have that if you have cancer, you're dead. There's no point in doing anything because nothing works, or if you've got it, that's it. So changing fatalistic attitudes is a major, major issue that we have to face. And one of the key communication is actually, yes, there is something you can do, actually. There are things, if we find cancer early, you're more likely to survive. Like Harriet showed the change in survival, depending on the staging of disease. So we have actually put in place quite a massive campaign using social marketing. And the screening uptake in Glasgow shot from 50% to about 60%. Now, the side effect of that was that the service is now complaining that we have capacity issues. And certainly, it's not going to be easy when the next study comes along, and this is the bowel scope, or the flexible sigmoidoscopy. There was evidence coming from England that if you do flexible sigmoidoscopy, you identify a lot of adenomas in the sigmoid colon that actually have the potential progression to cancer. And there would be a potential reduction in the cancers that develop later on. Now, one Sunday morning, I was watching the Andrew Marr show, and David Cameron was on the telly interviewed as new Prime Minister, and he advised us that we're going to implement the bowel scope in NHS England. And that's how decision gets taken sometimes. And I thought, is he saying something? So, what's the role of politicians in terms of how things happen? England now is running the bowel scope screening. They had several sites. And Scotland, we were starting yesterday, but I'm starting tomorrow. And the major issue is capacity for colonoscopy, because yes, you can guess how many people might take it up, and you just don't know. You can go and guess, but something happens. And the reality is just a guess. And that's what I learned. And you'll see other programs I'm running. It is your best guess, and you have to have the humility to say, this is what I thought based on what I knew at that point. Some of you might recognize this is a Fundai, and one of the programs I also implemented and was involved from the beginning was the diabetic retinopathy screening. The decision-making process in this instance was fairly complex, and Karen Facey, you've seen this morning, I don't know if she's still here, as chair of the Health Technology Board for Scotland, she led the technology appraisal of how to implement a cost-effective program to screen for diabetic retinopathy in NHS Scotland. So we had a very sound process that recommended that we implement the program, and is now running successfully. We have about 80% uptake in the program, and that's in Glasgow. Glasgow, it's simply because of the deprivation present, is less likely to achieve targets, but we are managing to achieve that. And the latest program we have implemented in Scotland is the abdominal aortic aneurysm. And this screens men using ultrasound at the age of 65 as a once only. And again, the retired director of Bitson sent me a personal letter saying, why are you not publicizing this screening program more widely? Because he just got the letter and he knew nothing about this. The answer is capacity. Because screening programs come in addition to everything else we do. We have a lot of talks about disinvestments, but we have not seen meaningful disinvestments unless we replace with something else. And certainly while the anticipated impact on vascular services for surgery from AAA has not been realized, and we don't know why. Probably because of the impact of secondary prevention for cardiovascular disease. Certainly, the screening program sees about 80% of men taking up the offer. So again, capacity, capacity, capacity. This is just an oversight of what we offer women in pregnancy and newborn. So again, a lot of programs well embedded into the pregnancy pathway. I'm very happy to give you a lot more detail, but the most challenging was the implementation of hemoglobinopathy screening. Because if once you have the ancestry questionnaire and the blood test and you're at risk of, or you're a carrier as a female, we have to test the partner. Now, you have no idea how difficult it is to actually get the partners to turn up and be tested. So we're working on that. We're nearly there, but we're not quite. Breast screening, a lot of controversy, a lot of issues about overdiagnosis. Again, we are changing. We use the analog mammograms. We're going to implement digital mammography, huge IT changes in the whole fleet. Again, convincing women to take it up. We're getting there. You'll see this poster. I showed this poster to my board, and I said, I would have never dreamt of this. We've been running cervical screening for a long time, and general practitioners were awarded through the old contract for reaching 80% uptake. In 2004, we changed the contract, and we've seen a dive in the uptake. So we allow women not to turn up. And everyone said, what's going on, what's going on? So we scratched our heads, we changed the leaflets, we changed the way we inform women, we engage them. Nothing happened. So one of the staff that works for me was at the university and was studying social marketing. And I thought, well, if McDonald's can do something, then get us to do all the wrong things. Can we engage with the public to maybe do the right things? So we use the social marketing approach. So you look at the population, identify the biggest, you segment it, you're very clear about them, you understand them, you do qualitative research to understand all the meanings. And what are the things? Because us professionals and middle-class women, we have some ideas. But when you're in your 20s, early 30s, and you live in the most deprived area of Glasgow, well, we need to understand what the issues are. And it had nothing to do with informed choice. It had nothing to do with where the cervix is. It was the fear, the embarrassment. They were all things that we have never thought about. So this poster it won't be the most embarrassing thing you'll do in the next 3 years. And actually, there's a video clip that goes with it, and the girl walks in the bar with a dress tucked in her knickers. Then she walks into a male toilet. And another one, she's looking at the wrong man because actually the man was speaking to his girlfriend who was just behind her. So it's putting things into the context and gaining those meanings for people that actually, going to see a trained nurse who's professional and takes 5 minutes, although the whole appointment is 20 minutes, it's very little, makes a big difference. So the laboratory was terribly upset because they had to pay overtime for people because women are taking it up. And we are evaluating the program. So it just shows how do we engage with the people? How do we have the shared decision-making, but understanding what their meanings are, exactly what Harriet said, and what we think and what they think are two different things. I'm going to stop there. This is a view just in Glencoe looking towards Glenetive. It's fabulous, encouraging you to get out and do some exercise and visit Scotland if you can. It's one of the most beautiful places on earth. And it's also, it's leading in healthcare quality and safety and implementing big programs. So happy to take questions.
Any questions for Amelia?
I have to. You passed over quite quickly the issue of breast screening, and I suppose I'm just going to ask a question. Would breast screening have ever started if we had known that you could detect pathological cancer on biopsies that were in fact going to end up being benign pathology? My challenge would be is that breast screening, as it currently stands, would never get through Wilson's criteria for screening.
Hindsight is always wonderful. And again, it's weighing benefits and risks. And the recommendation even nowadays, we have not stopped screening, and we still offer it to the women. And the latest campaign says it's still, if it's found, yes, you're at a risk of getting treatment for something that is not going to have ended your life in the long term. Unfortunately, based simply on symptoms, and Detect Cancer Early showed us, is that symptoms are very poor prognostic, very poor in actually identifying cancers.
Okay, well, thank you. All three speakers have shown actually that there are challenges in actually involving patients in shared decision-making, but there are also methods involving the public and policymakers in screening programs, but they have shown some of the difficulties and the challenges, but also some of the promises of the more recent approaches. I want to thank all three of them, not only for ending in time, actually, their presentation, so it's sharp, 3:30 sharp, and we can also go to the coffee break, but especially for sharing their thoughts, and I would like to do that with an additional round of applause. Thank you so much.